All right. So those on Zoom, if not. So everyone should be able to see our schedule. We are going to do the best we can. We have a couple of doctors coming in who are going to be talking, so just bear with us while we're putting their computers on for their presentation. We plan to have about 10 minutes or so at the end of every session for question and answer. We will try to keep ourselves to the schedule as best as possible. Again, feel free to take a break, whether in person or on Zoom, to go to the bathroom or anything like that. So we are going to do the introduction. You guys just had lunch here. Hopefully you had lunch at home. What we're going to do is we're going to do the introduction to UVA's team. So let me go ahead and grab them, go around the curtain and bring them in. Okay. Oh, so for those who don't know me, I forgot to tell you. Most of you guys know who I am. I am Sarah Lincoln. I am the president and secretary of the Parkinson's Activity and Resource Center here in Charlottesville, Virginia, where we do exercise, support, education, and socialization. All right, now you have class is dismissed. Thank you so much. All right, so
Saturday. The program.
there's the people. All right. They were all conversing, so they weren't ready yet. So here we have we're going to have OTs, PTs, nurses, neurologists, anything that you can think of at UVA, we're going to have. So let me take the floor over to you, sir.
Oh, thank you everybody for being here. My name is Renzo Figari. I'm one of the movement disorder neurologists here at UVA. I see some familiar faces, which is great to have you here. This is something that I've been working for a few years to try to get together not our community more engaged with our clinic. So UVA being out there with you, with our community with Parkinson's disease, to try to help it with education, help with resources. So I'm really happy to have joined with Sarah in this event, which has been a great resource. And so this is part of that collaboration, working together with Park, which is doing some amazing things for our patients. But today, I don't want to steal the show. I want to really introduce the team that is working here at UVA. So I don't know, do we have the team there?
I think they have to put their sandwiches down.
Yes. Yeah, come. Don't be shy.
Yes.
Hello, everyone.
I'll let you introduce yourself.
I'm Alyssa Higginbotham. I'm one of the movement disorder specialists here. I'll be talking to all of you all later about the surgical treatment of Parkinson's. I'm a new face to you all, actually, because I just moved here from Cleveland, Ohio in September. So glad to be here.
You're welcome.
Thank you.
I'm Joy. I'm one of the nurse care coordinators. So when you call into the clinic or you might chart message in, it might get routed to me. So nice to be here.
I'm Lauren. I'm one of the occupational therapists that works in the multidisciplinary Parkinson's clinic, both on the atypical side and on the comprehensive side.
I'm Lauren. I'm the other nurse coordinator for the movement team. So I'm also on the phone and in the MyChart messages as well.
I am also Lauren. I am a clinical research coordinator, so you guys will probably at one point get an email from me asking you to join a research study that we have going.
I'm Melissa Fox. I'm the physical therapist that worked in the company.
I'm Hannah Caballero. I'm also a clinical research coordinator. You may know me. I used to be the social worker for neurology also, but you may also get emails from me asking you to be in studies.
Great.
We also have Dr.
Great team that we have at UVA. We have also Dr. Shah, of course, he's gonna come in a few minutes. He's gonna start today opening, talking about our just newly opened comprehensive multidisciplinary Parkinson's disease clinic. I'm not sure if any of you have been able to participate of that with the idea to, it's a long day in clinic, but I don't wanna make Dr. Shah's presentation, but it is to bring a multidisciplinary care with physical therapy, occupational therapy, speech therapy, all into one clinic visit and try to come out with like a roadmap for the next few months in the management of Parkinson's disease for each individual patient. And Dr. Shah is going to come to talk a little bit about that. After that, Dr. Higginbottom will talk about some of the surgical treatments. I'm going to be talking about a little bit about medications and things that we think may do. And then Dr. Philip Lee, who is our movement disorder fellow, who's been here at UVA for almost a year, is going to be talking about the future that we have ahead for new treatments and management of Parkinson's disease. And at the end, we're going to have a roundtable to discuss different options of how you can start to take charge of your Parkinson's disease and try to help manage this better at home. So I'm really excited, and thank you, Sarah, for everything you've done.
Absolutely. So we're just waiting for,
Dr. Shah is on his way.
okay. All right, so Dr. Shah is on his way, hopefully here momentarily. That introduction definitely went a lot quicker than I thought it was going to be. 15 minutes, but that's okay.
That's okay. People are still enjoying the lunch.
Yeah. So I know at home, you're not going to be able to see everyone that we have here, but I can't do math, but it seems like we have 55 to 65 people here. How many people here have Parkinson's disease? How many people have had Parkinson's disease? Keep your hands up. I didn't put them down yet. At home, you guys can raise your hands as well. How many people have had Parkinson's disease for over a year? Okay. If you've had Parkinson's disease for more than 5 years, keep your hands up. If you've had Parkinson's disease more than 10 years, put your hands up. 15 years. 20 years? 25 years? 30? 35? 30 years.
Wow.
So Robert has had Parkinson's for, I can't see that on Zoom, but Parkinson's had, Robert has had Parkinson's for 30 years. He's also had DBS as well, correct? Right. We do have a couple, one of his book at the gym. If you guys are interested, you can also get it on Amazon as well. It's his journey on Parkinson's. I also have to give a shout out to Robert for facilitating getting this coordinated through Darden. Let's give Robert a round of applause. We definitely realized that we sold out a lot quicker. I think within a week and a half, we sold out of spots. So we know next time to get a bigger room. I think as Jaws would say, I think.
Yep.
So, did anybody have any questions before we get started? Yes, ma'am.
I asked about, we parked in the parking garage.
Okay.
So we don't, I mean, is there a charge? Is
Uh,
there a
so they did tell me to let you guys know that you should pay through Park Mobile, which is the app. I know that they also told me you can kind of be safe parking in the garage. I know I paid for parking, even though there was like no sign for it, I still paid for it. You can set up through Park Mobile, which is just the online app, or you can just deal with it.
And what would that be?
I don't know. I just know that when we signed up, they said this parking not super isn't free. Yes, ma'am.
UVA allows one warning ticket per year.
Okay.
Might be today.
You're like, I live in
Thank
Richmond,
you,
so it
Liz.
doesn't really matter, right?
Someone.
Zoom people said that you guys can't see the whiteboard. Is my share screen not showing at all? Someone tell me if you guys can see the schedule at all or no? I know you guys can.
Yeah.
I meant the Zoom people. Gary, can you guys see the schedule? You can see this, okay, yeah, we can, perfect, excellent. Appreciate it. All right, so maybe, Dr. Shaw got, ooh, Lord. Nap there, Lord.
So.
All right, use the bathroom if you need to. Go get some napkins. We're gonna, while we're waiting for Dr. Shaw, here you go. We're gonna bring in some of the reps, our sponsors. They, helped, thankfully. Oh, you're not some of the drug reps.
They said they could see it.
Yeah.
You know, keep them up here.
Oh, just, okay.
Sure.
All right, just bear with us one moment while we are stop sharing screen.
Right.
All right. All right, drug reps, who wants to go? Let's do, whoa. I don't know what happened there. There we go. All right, so, of course, Abby. Now, come on first, alphabetical. That way I don't forget anybody. You're talking about you.
Oh, okay. Hey, good afternoon, everybody. Omari Peeler with AbbVie Pharmaceuticals, representing Duopa therapy. I got a booth out here, but Duopa is just carbidopa levodopa, but it's continuously delivered. So it's not orals. It is made to manage motor symptoms, reduces pill burden, and improves on off time. So again, this is more for advancing Parkinson's disease patients. But if motor symptoms are worsening, you are taking more and more pills, and you are looking for something, Duopa is something that you should definitely have a conversation with your neurologist about. It's a great therapy for those that go on it, and your life will improve greatly, not just for the patient, but the care partner that is counting the pills, making sure the patient gets it, and so on and so forth.
How does it get in your system?
Okay, so we're gonna get into all that. So it is actually pumped. So one of the misnomers is that over time, your body gets used to levodopa. It's not the case. Dopamine and gut health go hand in hand. So what's happening is it's taking those pills in the gut longer and longer to break down the pills, get to the small intestine where it's absorbed, and then push back up to the brain. So Duopa is pumped directly to the small intestine all day long over a 16-hour waking period. Instead of having those ups and downs where you take a pill and wait for it to get here, feel good, and you crash and back and forth, it keeps you in that sweet spot all day long for your 16-hour waking period. The other benefit is it's specifically titrated or dosed for each individual patient, right? Because you see one Parkinson's patient, you see one Parkinson's patient. So you can get as low as 2 milligrams per hour continuously, or as high as 400 milligrams per hour continuously, which really helps in manage each individual's, again, motor symptoms.
Does that involve a cervical implantation?
It does. So it's outpatient. We liken it to a colonoscopy. Takes about 45 minutes, very small hole into the stoma right here. And it is reversible. So if something else comes out or it doesn't work for you, you can go back, have the tube pulled, 100% reversible. Great question. Anything else? Yeah.
There must be downsides to it. What are they?
I can just tell you what I hear. Most people, when they hear procedure and pump, turns them off. But really, just think of it as carbidopa levodopa. So any symptom you could have with carbidopa levodopa, you could potentially have with Duopa, but that's all it is. And then obviously there's something from external. So you care for the stoma, the tubing. But typically patients don't have issues.
Is it geared to be changed that if you need to have a dose every 4 hours, in other words, one in between the last one and the first morning one?
So it's, you wake up, connect the medicine cartridge and press start, and the machine, the pump does that all day. So you're
Oh,
not doing
it-
anything.
you have to, but you have to initiate each
Yeah, you just connect
method.
it.
So
Yep,
somebody
press
has
start.
to do it.
If you guys have any more questions for Mari, he'll be out in the hallway. Now that let's do a quarter real quick. While he's still working.
Everybody, my name is Rick Hoyda. We're Porta Therapeutics. I represent a drug called Inbrija, which is an inhaled levodopa used for the treatment of OFF episodes. Can be used up to 5 times in a day. A lot of folks will use it when they first wake up in the morning if they're having a hard time getting going, and then for those what if moments throughout the day.
Again, any questions? Ask them during the. I'm just trying to get through over. Boston Scientific, we got 2 people here. Come on over.
Hey, I'm Trey Smith. This is my colleague.
I'm
Sadie. And we're with Boston Scientific. We do deep brain simulators. Yeah, we do deep brain simulation systems.
Steady state electrical therapy in addition to your.
Excellent.
Jacob Elias with Medtronic Deep Brain Stimulation. Same therapy as Boston Scientific, just another company.
It's very collegial, isn't it?
All right, so what I'm gonna do is I'm going to share our screen.
Thank you all for sponsoring this event.
Yes, thank you. If you have any questions for those
Sponsors.
thank you, sponsors, drug reps, please go outside and talk to them during the breaks, all right? We are going to go ahead. Bear with me one moment. We are trying to get this to work. Again. Everyone, please welcome Dr. Shaw to the party.
Nice to see everyone. I'm Dennis Shaw. I'm one of the movement disorders neurologists at UVA. I see a lot of familiar faces that I'm glad to see, and some folks I haven't met yet. Apologies for running a little late. I was stuck in clinic, running back, and then dealing with Charlottesville driving. So it took me a little bit to get here, but while we're getting set up, I certainly want to acknowledge Sarah and Renzo and the whole team at Park for setting up this education day. I think it's great. I think it's something we want to make sure that we're really acknowledging and you know, as potentially appropriate or inappropriate as this adjective is or verb is, let's celebrate Parkinson's Awareness Month and really make sure that we are continuing to build community in the way that Sarah has done with Park and Rocksteady and make sure that, you know, nobody feels alone when we're talking about dealing with Parkinson's. So that's a little bit of the theme of what I'm going to talk about today, which is the case for interdisciplinary care in Parkinson's. And then whenever I'm ready, whenever you're ready for me.
Yeah, I'm ready.
Am I ready? I don't know if I'm ready.
Okay.
Sarah's ready for me. So I will.
Yeah.
See if the.
Should be arrow down. I'll figure it out. We'll figure it out. We'll figure it out.
So as I mentioned, you know, this is sort of a development that we've tried or initiative that we've tried to develop really now almost over the last year. To really take advantage of what interdisciplinary care in Parkinson's can achieve, or what are, you know, potential benefits, and of course, what are potential issues or challenges that come. And so I'll give a little bit of a background with the, you know, the outline, a little bit of a background and the current state of affairs. A lot of this doesn't just apply to Parkinson's, it applies to kind of chronic medical disease or conditions in the United States and really around the world. I'll talk a little bit about a framework for a comprehensive Parkinson's clinic and what are potential benefits and kind of what are areas to be explored, potentially challenges and things like that. And I want to leave a little bit of time at the end for people to comment or to ask questions. So I want to start with a little bit of nomenclature, and there's different sort of concepts, and a lot of these are used interchangeably, though they're not entirely synonymous. So multidisciplinary means sort of studying or interacting with a disease state or some subject where different disciplines sort of comment or provide their own insights without necessarily an integrated or consensus type of approach or paradigm. And then interdisciplinary, which is sort of more along the lines of what we're considering, sort of uses insights of different disciplines, but to really create a more cohesive sort of narrative plan or to come to consensus agreement about what next steps would be. And then there's transdisciplinary, which definitions vary, but often it's sort of looking at sort of affecting change on a more global, maybe even societal level. And maybe that's a bit of an aspiration for any initiative we have, but perhaps out of the scope of what our next stage is. So a little bit of a background. A well-known frustration with Parkinson's care, what I hear from a lot of people, and for chronic medical conditions, neurologic and otherwise, is that there can be a lack of consistent communication between different parts of care teams, care providers, primary care providers, specialists, therapists, other things like that. And often, it's sort of like, hey, my physical therapist sent a note. Did you see it? No. This is what they told me to pass to you. And it's kind of like, okay, paperless system, here's a little Post-it note. And that's not necessarily an ideal way of sort of communicating and providing cohesive care on a disease that can be as ubiquitous as Parkinson's can be. And it can lead to a sense of isolation. I think that the nature, the paradigms of healthcare in the United States have changed significantly, even in the, I'm not going to say how many years since I've been done training, but even in those years till now, and certainly most of our lifetimes, gone are the days of kind of the country primary care physician who quarterbacks all the care and sort of takes input from different people and says, this is what we ought to do. And now it's a little bit more of a mosaic where there may not be as good communication and may not be sort of the same direction of facing that we'd like to have in terms of considering what treatment options are, what diagnostic options are, or just managing the disease as applies to people, family members, or the community at large. And so that can lead to a sense of isolation or a feeling, and I don't know how many of you have felt this way, where people often feel like they have to drive their own care. They have to ask the questions. They read about things and say, hey, we've got 30 minutes with our neurologist and we have all these questions to answer, and they're asking me questions about my bowel movements and things like that. So, which is important, but if that's not on the top priority list, it may not be the best use of time. And so I think that can lead to a lack of guidance or direction in terms of how we approach care. And there can be tangible effects of this, detrimental effects. There can be increased uncertainty and anxiety. Plenty of people where a diagnosis of Parkinson's stops life entirely. And the reason for that is the uncertainty about what the next phase entails. And, I can ask people, are you going on any trips? No. Why not? I have Parkinson's. Well, why can't you go on a trip? Because I have Parkinson's. Can you get on a plane? Can you go? And the answer is, well, I can, but I don't know what's going to happen. And it's sort of, going to Kansas City may not require a huge amount of effort. Whether you want to go there or not is a separate issue. But the important thing is that there can be a disability just from having a diagnosis. And what we want to do is try to unburden that as much as possible. And honestly, what we don't do a good job of is unburdening that as much as possible. It can lead to poor outcomes. Poor communication can lead to unnecessary, potentially excessive care, emergency room visits, interventions that come from that, particularly from parts of the healthcare system that may not be as familiar with Parkinson's care. It can lead to suboptimal care, not applying the right treatments at the right time, or not offering the right treatments, and just overall poor quality of life. And it's important to note, Parkinson's doesn't just affect an individual, it affects family members, it affects couples, it affects families, it affects extended families, employers, society at large. You know, and that can lead to interpersonal conflict, and nobody wants to have a relationship where a spouse feels like they are resentful of their spouse for being ill or having an illness. And that, you know, is something that can come up, and that's something we want to help support. We can't take that away entirely, and that can be part of having a disease, but at the same time, I think making sure that people know what resources are available. And there's, you know, we know there's, and I'm going to talk about this, clear benefit of earlier and more active intervention of rehabilitative therapies. A lot of the work in terms of developing interdisciplinary care models has come from geriatric medicine. And there's sort of this comprehensive geriatric assessment, which kind of looks at, you know, overall global function, global support, and trying to develop sort of risk stratification based on that, and trying to intervene to achieve better care with less potentially more mortality and keeping people at home longer. And there's been some development of Parkinson's disease multidisciplinary clinics in research with it, but it's certainly more heterogeneous. So I'll go through a couple of studies that have looked at Parkinson's sort of multidisciplinary care clinics and what sort of evidence or what outcomes they've shown. This is one from Krauss in 2022 that looked at sort of the effect of just a very short 3-week kind of multidisciplinary clinic paradigm for people with Parkinson's disease, and it was sort of embedded in a normal Parkinson's clinic. And it was either 2 or 3 days a week. And you see sort of the people that were part of the clinic here were fairly similar. You can see some of the characteristics of them. I can't read the screen there, and I've got the chat over here, but oh, Sarah's always good. But she doesn't put me to task at rock steady. So you can see, you know, there's a male predominance of these participants, as is the case in Parkinson's. You know, there's different staging systems, and I really discourage a lot of people from thinking too much about what stage am I in, because it's really used for research purpose, and you can have people who have a much higher quality of life at a stage 4 than at a stage 1 or 2. But looking at who had tremor, who had more sort of a slowness stiffness syndrome, who had deep brain stimulation, things like that. What they showed is that there was significant improvement in all of these measures that I have here. So severity measured by Parkinson's rating scale, APDRS. Part 3, there was a significant statistically meaningful difference between people at the beginning versus at the end of the multidisciplinary clinic course. There's change or improvement in balance of this BBS-Berg balance scale. There was improvement there, improvement in dynamic balance of both sides of the body, improvement in mobility, as measured by this timed up and go sort of gait test, and just overall mobility and physical fitness was improved. And so that's great to hear. And I put at the bottom there, so the overall medication dose was reduced by 110 milligrams, so about a tablet of Cinemet equivalent, which isn't a whole lot, but it certainly shows that there's some benefits that clearly are not just physical, but can have an impact on, for example, medication dosing. Now, this was fairly short. It was 3 weeks. It's unclear how sustainable that is. And actually, this is some other data about non-motor scales. So looking at depression, looking at anxiety, quality of life overall, apathy, sleep measures, cognitive function. Not all of these were statistically significant, particularly from a cognition standpoint, though one could argue 3 weeks is a fairly short time to try measuring those changes. But improvement in sleep, improvement in quality of life, mood, depression, those things go to kind of who we are. So those are existential changes that I think are measures that are important to note. And I'll make a note that, you know, we do clinical research, we do trials, whether it's with medications, whether it's with surgical treatment. So this trial that I mentioned here is an early stim. It's related to deep brain stimulation and considering using deep brain stimulation earlier in Parkinson's versus later. It's a good trial, but the thing I want to note is a lot of these benefits seen in this multidisciplinary care report from 3 weeks showed people improved without any change in medication. In fact, a slight reduction in medication, certainly without any surgical intervention, in a way that exceeded the sort of placebo or control group of many of these active sort of experimental therapeutic trials. So I think that it also goes to the question of when we have a trial, whether it's for a new medication or for a new surgical treatment, you know, is the control arm of the what we consider best medical treatment really the best treatment if we're not sort of having people in a more multidisciplinary integrated care approach model. This is another study that looked at integrated care, and they did a sort of meta-analysis looking at many different trials of randomized controlled trials of integrated care versus standard care. And this is just a sort of review of kind of what the cross, multi, interdisciplinary, and integrated care definitions are. But I did want to show this, and it's really small, and there's not really a need to go through it in detail, but each sort of spoke on this wheel is a different study that this meta-analysis looked at. And it looked at who or what type of care providers or disciplines were involved in the different studies that were looked at. So, you know, there's a movement disorders neurologist. Okay, that's fine. There's physical therapists, RN, nurses, occupational therapists, speech therapists, psychologists, neuropsychologists. And I think those are fairly common things that many of us have interacted with. So when I talk about developing an interdisciplinary care clinic at UVA, those are really important individuals to have under one roof. But there's some, you know, some reports that even had, and I'll go down to the bottom, a gastroenterologist. That would be, you know, that would be a dream to have in a neurology clinic. I failed every time I've tried doing that. There are music therapists, there are dental hygienists, there's sexologists. So some of these clinics have been quite comprehensive, and I'm not sure how exactly they are able to accomplish all those things within like a, you know, 4 to 6 hour clinic visit, but nevertheless. So the current state of affairs is Parkinson's care is fragmented. And patients can enter PD care through their primary care providers, neurologists, physical therapists, occupational therapists, speech pathologists, neuropsychologists, et cetera, where it's sort of like, hey, there's a concern about Parkinson's. Now you're shunted into kind of PD care. But coordinating between these disciplines is challenging, even, you know, in a UVA ecosystem, even in a place where it's a large health system in a relatively small metropolitan area. And there are really very few centers that have true, you know, integrated PD care models. So in terms of developing a framework for a comprehensive PD clinic, and we're in sort of a pilot phase now. I think some of the folks in this room might have been part of it already. But what we wanted to do is bring together a core team of movement disorders neurologists, physical therapists, occupational therapists, speech language pathologists, neuropsychologists, nutrition, and then plus or minus genetics, neuropsychiatry, and neurogastroenterology, which is a very rare specialty. And what we planned is a weekly full day clinic, and that's kind of as our start. And the goal is to try expanding it to every day, at least of the work week, 5 days a week. And sort of in thinking about who would benefit most, thinking about people with Parkinson's who would benefit the most from kind of comprehensive and wraparound care that affects, or care that addresses not just people with Parkinson's, but also care partners, family members, et cetera. And the expectation, you know, given the overall numbers and talking about 1 day a week with certain weeks like Christmas and things like that being accepted, you know, talking about for right now, perhaps people coming to the clinic on the order of once every couple of years. So not ideal, but that's interleaved with the normal neurology clinic visits. And this is an example of, for how an individual might go through the clinic. So right now we have capacity for 8 patients in one of these clinic slots, and we could potentially denote more urgent care if there's some change or acute change in somebody's status, and then have people see the interdisciplinary care team in 1/2 day. We have a team discussion in the middle of the day, and then see, for example, a neurologist in the afternoon, or sort of the flipped schedule. And some of that can be dictated by distance. If people are coming from over 2 hours away, getting there by 8 or 9 a.m. might be challenging to do. What are the potential benefits? Well, you know, we can say better care for patients with PD. How we define that can vary quite a bit. But I think facilitating the right interventions at the right time, you know, talking about things like getting somebody into therapy services is important really at any time. But certainly if there's a change, we want to make sure we're aligning somebody with the treatment they need to have with the specialist that they need to have at the right time. Potentially making sure people go on to advanced treatments if they need to, whether it's surgical, whether it's infusional treatments. We'll call back to our sponsors there. And then patient caregiver satisfaction. So we want to make sure that there are enough resources where people know, hey, I know who to communicate with. If I have a message, about something that I'm not sure Dr. Shah can answer, I know I can send him a message and there's a team of people who know me that can help answer the question. And then team satisfaction. So, I think that it's important that we all feel a sense of collegiality and that we all generally have a sense that we like each other. And so the team is sitting back there. Hopefully they like each other, and whether they like me or not doesn't matter. I'll take the Billy Martin approach from the Yankees. So from a research standpoint, this is important too, because I think most of the people in this room are probably pretty engaged and motivated, not just in their own care, but to learn about what's possible, what's coming up, from a research standpoint, but also to participate in research. And having a paradigm where we have an enriched clinic population that then potentially allows for our clinical research coordinators to come in and discuss trial participation with people in the clinic is an important thing. And then sort of a little bit more of a longer term plan is to consider some more government funded research and patient outcomes research. So the National Institutes of Health has this CORI grant mechanism, which is patient-centered outcome research. So rather than the more typical, hey, what's a treatment? Does this work or not? We'll fund a trial to show that. It's more to say, what are interventions or what are different types of ways of delivering care that focus more on patient-centered outcomes? And so the people who help determine that are patients, caregivers, national organizations, things like that. And I mentioned clinical trial participation being more efficient in getting people to the right studies if they're interested. So what are some areas to be explored? Well, it's important to be time efficient because we have great people at UVA. There are great people at movement disorder centers around the country. And they could probably spend many hours, but it can be a long visit. And so we want to be as efficient as possible. We don't want somebody to come to the clinic and be there for 8 hours and it's sort of like, okay, how do you feel at the end of the day? Exhausted, So we have to find a way of making sure that we have this, we deliver this sort of comprehensive Parkinson's clinic in a way that's time efficient, but still effective. Potentially exploring virtual options. So often the people that need this type of care are the people who have the most difficulty physically making it into a clinic setting. And so, thinking about ways of trying to deliver this clinic virtually, I think that'll be sort of our next iteration or next phase of developing this clinic. Communication post-visit. So somebody has the visit, who do they communicate with? How do they communicate? I think we want to make sure that it's as expanded of a group as possible, but we also need to work on kind of our flow to develop that. And sustainability, there are going from PowerPoint to Keynote. Never done that before. All right, so it's a resource intensive care model. And so I think that we've been fortunate that the health system has been quite supportive so far in us developing this pilot and moving on to an official launch, ideally in July or hopefully in July. But it takes a lot of resources, takes a lot of manpower, space resources, and other resources. And so making sure that we have sustainability from that standpoint is really vital to not just maintaining what we have, but also trying to expand it to more days a week and reaching more people. So some acknowledgements here. The Comprehensive Parkinson's Clinic team at UVA. So I think Lauren and Joy are somewhere. Lauren and Joy are clinic nurse coordinators, and they're fantastic. Dana Morrissey, Renee Breaker, Melissa Fox, Lauren Berman, Ellie Hayden, Shannon Riley, the Movement Disorders Neurology team, Diane Huss, Susan Dietrich. I think all of you know Susan well. And Shelley Newstep Watkins, Pam Bondurant, plenty of other people that have really helped make this clinic get off the ground, and we have a lot more work to do, but I think with input from all of you, hopefully as many of you cycle through this clinic, it'll really be important to kind of help make it as beneficial and as comprehensive as possible. So with that, I want to leave some time for questions if there are. Thanks for having me.
Yeah, I was diagnosed with Parkinson's about a year ago. But 10 years ago, I came here to do the chaplain residency in the hospital. I'm now a hospice chaplain, have been a hospice chaplain for quite a while. I'm wondering if there's been any thought at all about including a chaplain.
I think somebody mentioned it and we're like, that's a great idea. And then we kind of didn't go forward with, but I think that's a great, I think the value of chaplain services in both the inpatient and outpatient setting is probably not as recognized as it ought to be. So I think, I'm glad you mentioned that, and I'll make a note of it. And actually, Dana,
Actually, I'm talking.
yeah, see, Dana,
Might have one, or at least some of the clinics.
Yeah, I think it would, with hospice using chaplains and social workers in an interdisciplinary approach, I think it would be wise to do that.
Shout out to Dana.
What about funding and space for this clinic?
Yeah, that's one of the challenges. That's one of the things moving forward. And I think we have, multiple approaches that we want to consider. One is to apply for grants. Both governmental grants, foundational grants, things like that, to ramp up, philanthropic efforts to really help get people to support the clinic, which is how a lot of these multidisciplinary clinics at other places have developed. And really get medical center buy-in and understand that, and which we've gotten so far, which is great, which is that, if somebody in a certain way, our healthcare system is a little bit skewed and sort of caring for care for complex chronic conditions doesn't generate revenue, but knee replacements do. Well, if somebody has Parkinson's, they'll get their knee replacement where they're getting their comprehensive Parkinson's care. And I think that any healthcare system probably recognizes that. Yeah.
I was glad to see that you have the gastrology as a very important part, but I didn't see lymph system in there. Because to me, with the lymph system being throughout the body, when Jay's had the longest and hardest stay in the hospital with lymphedema, and that's been going on since 2017. And each time it gets worse, and he has a constant in his system now. And we haven't even had a chance to get to the lymphedema clinic because he's in the hospital when they schedule it. So I think the lymph system is a very important part of this too.
I'd say two things with that. So one is sort of Parkinson's itself and our understanding of lymphatics as it applies to the central nervous system. Actually, one of our former chairs of our neuroscience department at UVA was at one of the pioneer labs to show that there's in fact a lymphatic system that involves the central nervous system, which prior to that hadn't really been demonstrated. And it was thought that the brain and spinal cord are sort of totally separate areas than systemic circulation in terms of lymphatic system. The second is that we want to prioritize specialties that are most applicable to the most number of people. And then, so I think that's an area of exploration, is to say, okay, lymphedema can happen, and lymphedema and Parkinson's can happen either due to some other underlying medical condition that's exacerbated in Parkinson's, or what we can often see is if one side of the body is affected or one limb is affected to a much greater degree, we can see increased swelling, poor circulation, and then with poor circulation, increased risk of sores or other things like that, infections, et cetera. We'll incorporate kind of those ad hoc types of specialists within a comprehensive Parkinson's clinic, I think is probably something that we want to develop perhaps as the clinic continues to iterate. As far as gastroenterology, the only clinic I'm aware of where there's a neurogastroenterology clinic with Parkinson's specifically is a Rush in Chicago. And I've communicated with the movement disorders neurologist that heads that program, and she told me, let's talk at the meeting that we're going to next week, and very challenging to do. So we'll see what she has to say when I talk to her next week.
One more thing on that, though. Since the lymph system has just been found to have an exit drainage system from the brain, and they've been trying to get using the vein system to get in there and work on bacteria and the amyloid plaque. Now they have the lymph system. If the lymph system has a drainage, it has a go-to point. So that might be another way to find to get into the brain and work on the amyloid plaques.
Yeah, and I'll say Parkinson's doesn't have too much amyloid deposition. That's more of sort of an Alzheimer's pathology. But I think the point is that's an exciting avenue for potential research development.
We have time for one more question.
So how do we join the team?
So, well, I think that's sort of something that, so right now, the clinic is something that's still in a pilot phase. And like I mentioned, we at UVA, we follow, one prerequisite is to have neurologic care at UVA, just because we have so much, such a large population, up to 2,000 people with Parkinson's that we follow, uniquely every year. The sort of the two kind of the bimodal distribution that I think we're prioritizing right now, people that are probably within a couple of years of diagnosis, where there's a lot more uncertainty about, hey, what are potential resources that might be helpful for me? Maybe now, but perhaps in the future. And people where there's a change in the Parkinson's to be in a little more of an advanced phase where, the status quo is not, has changed in a way that sort of the normal care paradigms, the normal paradigms of managing at home have changed. And where having this sort of comprehensive care and some wraparound elements to it can be really valuable. But ultimately, the mechanism we have right now is that I or Dr. Fagari or any of the movement disorders neurology team sort of let Joy and Lauren know, hey, we'd like this patient to come in X number of months to the comprehensive PD clinic. So more than that, I'd say Joy and Lauren run the show.
All right, let's give Dr. Shaw a round of applause. So we are gonna be taking a break right now. Bathrooms are right around the corner. Throw your trash away. We are gonna be coming back in about 10 minutes or so. Use the bathroom, stretch your legs out a little bit, grab some more beverages. I think the food was taken away. We'll have snack in about another hour or so, okay? Taking a break right now. We will be back in about 5 seconds. We're gonna start gathering people in from outside for them to come in and we will share our screen. All right.
Oh, that's another one.
I help.
Good thing I don't use a mic at the gym.
Jim got this. Parkinson's disease, surgery.
Good, thank you.
Weird, these are pretty. Stop.
All right, we have, whoa, we lost a lot of people.
There was a line.
There was a line in the bathroom.
Then we can't get to the way, so.
Yeah. Cool, gotta stay on time.
There.
Those people move slowly.
That's true. Yeah, you gotta have extra long breaks.
Whipper.
Yeah. Very soon, very momentarily. Can I get a thumbs up for people at home?
Yeah,
Can
so
you
I
guys
said,
see
okay.
Dr. Higginbotham's screen? Thumbs up, thumbs down for people at home?
Oh, there's a thumbs up.
Perfect.
This time.
All right, so we are gonna start with surgical treatments of Parkinson's. You all got introduced to Alyssa Higginbotham, who is new from Cleveland, right?
That's right.
All right, so she is gonna have a microphone. She is going to talk about that surgical treatment for Parkinson's disease. We may have some people coming in who've used the bathroom, so just make room for them if they're in between.
All right, can everybody hear me okay with this microphone?
Yep.
Wonderful. So I'm Alyssa Higginbotham. I'm going to talk about the surgical treatment of Parkinson's disease. Before I do that, I'm going to give you a few brief slides just on Parkinson's disease in general and the symptoms. Because when we talk about what symptoms respond or not to surgery, I want us all to be on the same page. Okay? So first of all, Parkinson's disease is a neurodegenerative disease. So what does that mean? That means that cells in the brain degenerate or die very slowly over time. And you can see actually that normal brain up there. You see that black stripe? That's normal. That's called the substantia nigra or black substance. That's the home for the dopamine producing cells in the brain. So people who don't have Parkinson's disease have a lot of those dopamine producing cells. But people who have Parkinson's disease, you can see they kind of lost that black stripe. That's because those dopamine cells degenerate or die very slowly over time. And that's actually what leads to the motor symptoms of Parkinson's disease. So when we talk about these medical treatments and these surgical treatments, they're not reversing that process and they're not slowing that process down as far as we understand it. But they are doing a really good job to treat the symptoms. However, just know that because this is a progressive neurodegenerative disease, these treatments that we're going to talk about, they're not a cure. They're not a catch-all for everything, okay? So keep that in mind when we talk about what surgery can and cannot do for your symptoms. What causes that process of those cells to slowly die over time in the brain? We don't know 100%, but we think it's some combination of the genes that you were born with and your environmental exposures that you accumulate throughout your lifetime. Aging is the biggest one. So every decade you have an exponentially higher risk of Parkinson's disease as you get older. And then some of these other things we've learned increase your risk of Parkinson's disease too. So exposure to pesticides, if you were a farmer and you were seeing all those kind of things throughout your career, solvents in dry cleaning, diabetes, cardiovascular disease, multiple different head injuries and traumas. All these things kind of accumulate and create the perfect storm in the right person with the right genetic makeup to cause Parkinson's disease. So what are the symptoms of Parkinson's disease? Well, we always talk about the motor symptoms. Those are the symptoms that affect movement. So the first is tremor. Generally, tremor is going to be on one side of the body at first, and then it can spread to both sides. It's usually there when you're sitting, relaxing, and distracted, not as much when you're kind of thinking about it or looking at your hands. And then the next symptom is rigidity or stiffness. So this is not in the joints. As we get older, we all get arthritis, our joints are stiff, it's hard to move. This is stiffness actually in the muscles themselves. So it makes it difficult to do things like pull a sweater over your head, or bend over to put your socks on, or reach around to dry your back off with a towel, because those muscles themselves are really stiff. The next symptom is bradykinesia. That's a fancy term for slow movement that is small. So if I tap my fingers, I can tap really big and fast and I can keep going. But somebody with Parkinson's disease, it starts to become slower and smaller over time. Bradykinesia can also manifest as decreased facial expression, drooling, decreased blinking, a softer voice, decreased arm swing when you're walking, and then smaller handwriting as you write longer and longer. The next motor symptom is postural instability. That's a fancy term for balance problems. At first, it happens usually when you're turning too quickly or switching positions, but it can lead to falls later down the line. Motor fluctuations are another really important motor symptom to be aware of. So this means that when you take your medication, you feel it kick in and your symptoms get better and you feel really good. But then the medication wears off and you start to feel bad again. So then you take another dose, it kicks in, you feel good, it wears off, you feel bad. And that cycle kind of happens throughout the day. That's motor fluctuations. And then the last motor symptom is dyskinesias. Dyskinesia is also related to the medication timing. So you take a dose of your medicine, maybe you're moving a little bit too much actually. Like Michael J. Fox, he had these little movements of his neck. In some of the later films that he did when he was talking to someone, you could kind of see a little extra movement. And then that kind of can go away and then come back with the medication cycle. So those are the motor symptoms to be aware of. But that's not the whole story. That's just what we see on the surface. I like this iceberg analogy because actually under the water, there's all these other symptoms. They're called non-motor symptoms. So these are things like speech problems, constipation, problems with blood pressure dropping low on you, difficulties with sleep and bladder, depression, anxiety, hallucination, cognitive impairment. Not everybody has all of these, but some people can have some of them. And they're actually really a big contributing factor to quality of life. So it's important to know about these non-motor symptoms. So remember these symptoms because when we talk about what surgery can do and what it can't do, these are going to come into play. So the medical treatment of Parkinson's, how do we treat all these symptoms? Well, we first try medication. The most common is going to be levodopa. There's so many different formulations of levodopa these days, it's very complicated. But that's good because that gives us a lot of options to work with. And then we also have all these other different medications that we can use alone or in combination with levodopa to try to make the symptoms better. But when the medical treatment is not enough, that's when we start talking about surgery. So I'll mention 3 different surgical procedures today: deep brain stimulation or DBS, MRI guided focused ultrasound or FUS, and carbidopa-levodopa intestinal gel, also known as DUOPA. So the first surgical treatment is DBS or deep brain stimulation. So what does this look like? A neurosurgeon will actually drill a hole through the skin and through the skull, and then they'll put this lead deep down into the brain. So it looks like a tiny little thin rod. And it goes into a nucleus in the brain, right in the middle actually, called the GPI or the STN. There's 2 different places they can target. And then they secure that lead in place with this little stopper at the level of the skull. And then they attach that lead to a wire that's tunneled underneath the skin. So you can't see it, but it's tunneled under the skin, goes behind the ear, and connects to a battery that's actually in the chest below the collarbone. And so this requires a night stay in the hospital. The neurosurgeon has to monitor you for any complications or any symptoms. And then you go home and this system is off for 4 weeks. And then you come to see me, a movement disorder specialist, and I can actually hook up to that battery with an iPad. And when I do that, I can turn the DBS system on. And there's so many things that I can do. That little rod that I showed you, it has 4 different contacts on it. So I can test all the different contacts. I can turn up the juice, so how much of the brain I'm gonna stimulate. I can change how quickly I stimulate the pulses. There's so many different combinations that I can do with this. So it actually takes several different programming sessions to reach the optimal parameters for you to control your symptoms. It varies by person how long this takes. But usually we can do it within a few sessions, and then over time, you know, we said the Parkinson's disease is neurodegenerative, it does progress over time. We can adjust the DBS to control for those symptoms that emerge. So it's adjustable and adaptable to you. You also have the ability to adjust at home too, within a safe range that we set. So you might be able to turn it up a little bit if you're having more tremor, or turn it down a little bit if you're moving too much, you have too many dyskinesias. So what symptoms do we expect to improve with deep brain stimulation? So what I tell my patients is, think about when you take your medication and you have your best on. You're feeling your absolute best. You feel like you can go out and golf or go for a walk or whatever it is you do. Expect that for longer in the day. That's what DBS can do. Again, it's not a cure. It's not going to fix everything, but your best on is what DBS can prolong. So it typically helps symptoms like tremor, stiffness, that bradykinesia, and those motor fluctuations. So instead of having all those peaks and valleys, I feel good, it's wearing off, I feel bad. I feel good, it's wearing off, I feel bad. You're smoother throughout the day and more steady. And then dyskinesias, it helps that as well. So this is what DBS can do. So what symptoms do we expect may not improve or may not reliably improve in everybody who gets DBS? The first is balance and falls. We tell you in the clinic that the levodopa that you take won't help your balance, and that's true. And DBS won't help your balance either. Now, it could indirectly help your balance because say your legs are really, really stiff and that's why you're falling. Well, DBS, like we said, can help rigidity or stiffness. So in that regard, it could indirectly help your balance, but it's not going to directly help that sensation of you turn too quickly and you kind of get off and fall. DBS does not help memory, and it can actually make memory worse in somebody who has dementia. So we typically do not do deep brain stimulation in somebody who has dementia because, you know, we have to drill a hole in the brain and then put a lead down through it. It's very traumatic to the brain that's already fragile with dementia. So we don't expect it to help memory. We also don't expect it to help speech problems. Sometimes I do see people who have a really low voice and they get DBS and it's better, but not always. And then people who have slurred speech, that doesn't tend to get better either, and it can actually get worse sometimes from the surgery. It will not help swallowing. And then freezing of gait is an interesting one. So if you have freezing, that means your feet get stuck to the floor and you're kind of trying to walk, but then you get stuck. If that happens to you only when you miss a dose of your medicine or your medication wears off, and then it gets better when you take your medicine, it's possible that deep brain stimulation could help that. But in some people, DBS actually makes freezing worse. So we don't do DBS just purely for freezing because it's so unreliable. So look at this slide because this is very important. Whenever we decide who should get deep brain stimulation, we're always thinking about what is the patient's goals and expectations? What are the symptoms that they actually want to improve and get better? And is that in alignment with the reality of what DBS can do? And if it is, then you could be a really good candidate and have a really good outcome. But if you are really wanting, the only symptom that really bothers you is your speech and your memory, then you're going to be really disappointed if you get deep brain stimulation because DBS can't help those things, right? So it's so important to be open and honest with your doctor about what truly does affect your quality of life most to see is that something that we can help yes or not. So when might your doctor consider deep brain stimulation? Well, you have to have Parkinson's disease for at least 4 years. Why is that? Well, because early on, when we first diagnosed someone with Parkinson's disease, there's actually a lot of conditions that can mimic or look exactly like Parkinson's, but they're not Parkinson's. And they tend to declare themselves after like 4 to 5 years. So we want to make sure that we're doing deep brain stimulation for the right disorder. That's why we wait to see, are you following the normal trajectory of Parkinson's disease? You have to be healthy enough to undergo brain surgery. If you're having a lot of breathing problems or heart problems, probably not a good time to get surgery on the brain. You can't have any significant cognitive decline or dementia because we said that doesn't get better with deep brain stimulation and it can actually get worse too. And then you want to be in a situation where your symptoms respond to the medication. It's just the medications are not enough to sustain you and to adequately control your symptoms. So that could be because you're experiencing significant motor fluctuations. You're having all these peaks and valleys. The medication works super well, but you have to take it every 1 to 2 hours because it keeps wearing off on you. Or you get a good effect from the medication, but then you get these troublesome dyskinesias where you're actually moving a little bit too much. It's working a little too well. And then there are some people that everything gets better when they take the levodopa, their stiffness, their slowness, they feel more energized, but for whatever reason, the tremor is stubborn, and it's called a medication refractory tremor. So those people are actually great candidates for deep brain stimulation because, like we said, that's something that can respond to the surgery. So moving on to the next surgical treatment, MRI guided focused ultrasound, or FUS. So this is a picture of Dr. Elias, one of our neurosurgeons, and he's doing this procedure. So what is this procedure? So in this procedure, you go into an MRI machine and they stabilize your head in this frame, and then they shoot these really high frequency ultrasound waves through the skull to focus them into a part of the brain right in the center called the thalamus. And those ultrasound waves become really, really hot, and they actually burn a hole in the brain. So it's kind of like creating an intentional stroke in a good place to hopefully control tremor. But that's why I like to tell patients when they come to see me and they say, oh, I want the FUS because it's non-invasive. Well, it's not really non-invasive, right? You're kind of heating up the brain and burning a hole in it. It's still invasive. It's just that you're not having to drill a hole through the brain. There's no cutting involved, but it's still a permanent spot that's being burned into the brain. So it's still something to really think about and consider. It is a brain surgery. The other thing about this procedure is that it only helps the tremor of Parkinson's disease because you're burning a hole in the thalamus, and that's the part that kind of controls the tremor. There's a cycle that's going on and on and on, causing your tremor to go on and on and on. And right in the middle is the thalamus, so burning that hole interrupts that tremor cycle to stop the tremor. But this procedure does nothing for the stiffness or the slowness of Parkinson's disease. So when might your doctor consider FUS for you? Well, if you have tremor predominant Parkinson's, there are some people that, yeah, they have a little stiffness and slowness, but it's very minor and it doesn't really bother them that much. Or it responds really well to like low doses of the medicine. It's just the tremor that's the main feature of their Parkinson's. So those people could be good candidates for FUS. Medication refractory tremor. So again, everything's getting better when you take the medicine except that tremor. That tremor is stubborn. Well, then this could be a good treatment for you. Or if you're just not interested in deep brain stimulation surgery, it is a commitment. You have to have that brain surgery, then you have to come every, month or so to get those parameters fine-tuned, and then every once in a while to kind of adjust the stimulation over time. So it's a commitment. Or if you're not a candidate for deep brain stimulation, if there's some reason you have memory problems or whatever, this could be a good alternative if you're trying to treat your tremor. All right, so then the last surgical treatment is carbidopa-levodopa intestinal gel, or duopa. So this one, the surgeon will cut a little hole in the stomach, and they put this feeding tube into the stomach, and then it terminates in the intestine, actually in the place in the intestine where the carbidopa-levodopa is absorbed. And then this feeding tube is attached to this pump. And this black part here is where all that carbidopa-levodopa gel is sitting. And you literally just infuse this 16 hours a day right into the intestine. So instead of taking a pill every 2 to 3 hours, this pump is just constantly giving you carbidopa-levodopa nonstop for 16 hours. The downside is, of course, you have to be attached to this pump for 16 hours. So you might have to wear a little fanny pack or something to carry it around. So when might your doctor consider duopa? Well, if you're not interested in deep brain stimulation, this could be a good alternative because it's constantly giving you that medicine, kind of like the deep brain stimulation, constantly stimulating in the background so that you don't have to have those peaks and valleys related to so many different medication doses. Or if you're not a candidate for DBS, or if you have significant Parkinson's symptoms, but not just tremor. Because if it's just tremor, again, then you could get that FUS procedure we just talked about. But FUS, like we said, doesn't help the stiffness, the slowness, the motor fluctuations, the dyskinesias. So if you have all of those, but you're not a good candidate or you don't want DBS, this could be a good alternative. The other interesting thing about Duopa is that it overcomes this issue of what's called gastroparesis. So a lot of people with Parkinson's disease, you know, everything is slow, so is their gut. And so their stomach doesn't empty very well. And so then medication will just sit there. We've actually seen like in studies that the little yellow pill, levodopa, sometimes sits there for like 4 hours after you take it in some cases. So then that dose didn't work, right? So this overcomes that issue because you're delivering the gel right to the intestines where it gets absorbed. So we talked about 3 different surgical procedures and what they can do and what they can't do and what they're like. But I want to leave you with this statement of patients with Parkinson's are like snowflakes, you know what you are like, because you might hear from your friend or somebody that you meet in your boxing class or whatever it might be that, oh, DBS was a lifesaver for me. Or they might say the opposite, that didn't work for me. And I don't want you to get discouraged or too hopeful and say, wow, okay, it was a lifesaver for them, it will be a lifesaver for me. Because it really is so individual, because again, it's all about what are your symptoms, what are your goals, and can we meet them with this procedure? And if not, maybe a different procedure is right for you, or maybe no procedure is right for you and we should try different medicines. So don't compare yourself to other people because everyone's situation is totally different with this disease. It's very, very unique, as you probably have seen. So always talk to your doctor about your goals, be honest about what you actually care about so that we can see if that procedure would be something that would help you. All right, so I can take any questions that you all have. Yep, go ahead.
In the DBS, you mentioned that there's 2 sites that they might use. What reason do they use one versus the other?
Yeah, so they're both actually equally effective. We've studied that to see is one better than another, but it just depends on the patient's symptoms. So for people who have a lot of dyskinesia, the one site is a little bit better for that because it directly kind of gets those dyskinesias down. But the other site actually allows you to remove more medication from your medication schedule, which also can decrease dyskinesia. So in the end, they end up kind of being a draw. Another reason to do one of the sites would be if you have a lot of what's called dystonia. Some people with Parkinson's disease get like neck turning, or their hand might take a posture that kind of cramps up, or their foot might cramp up on them. One of the sites is better for that. One of the sites is also a little bit of a bigger target, so it's a little safer because it's like a big, you know, target that you can hit. Whereas the other one, you have to have a lot of precision. You have to be really, really careful when you do it. You have to be awake during the surgery. There's a lot of different factors to kind of consider for the individual to figure out what are their symptoms, what are the features of their Parkinson's, do they want to be asleep or awake during the surgery, and which one would be the best. But in the end, they're both equally as effective. Yeah.
When I first heard about ultrasound, my reaction was very positive because I said, well, ultrasound is non-invasive, which you've said it is, but also since it's just ultrasound, it's painless. And I've heard then from a person who underwent ultrasound that it was not painless.
Yeah.
Is ultrasound painless or?
No, so you do have to have your head fixed into this frame and they kind of numb your scalp so that it's not as painful, but you do have this frame kind of digging into your scalp and then they're heating up these waves. So that shouldn't hurt, you know, they numb it up so that you shouldn't feel that, but it's not like a super pain-free process because you have to lie very still in this frame for a long time. And the surgeon will ask you, okay, hold your arm out. I want to see your tremor. You know, it's a very kind of like anxiety producing procedure and you're there for a long time. So I'm sure there is some discomfort,
But not long-term.
No, not long-term. So there are side effects from the procedure, like there's side effects of anything. One of the side effects is that you could get tingling or kind of weird sensations on the other side of the body. So it's kind of like if you have neuropathy, it can feel like that. Usually it's not like stabbing pain or extremely painful, but it's uncomfortable kind of tingling sensation. Yeah, that could be a long-term or at least a transient side effect.
Thank you.
Yep.
Hi, does the Duopa, that's Duopa?
Yes.
Does that treatment affect the freezing?
So it's kind of like DBS, we don't know. If you're one of those people who, when you take a dose of your medication, the freezing goes away, then having that medication constantly infused could definitely help the freezing. But some people, their freezing is not medication responsive, so then we wouldn't affect it to be Duopa responsive, because Duopa is just medication infusing all the time. Yeah.
I have a DBS implant,
Mhm.
and I'm wondering if, does the Duopa work together with it?
Yeah, you could get both. We typically would only do that if, for whatever reason, your DBS is kind of failing you. Like, we optimize it as best we can and you're still having a lot of symptoms. Then we could do a Duopa rescue as like a last resort. But typically people don't have both unless the DBS is no longer working for them for whatever reason.
I don't think I have mine high enough, so I need to.
You probably just need adjusted. Yeah.
I have it where it was in the beginning, so I need to.
Yeah, you need
Step
to
it up a little bit. Okay,
Exactly.
Thank you.
Anyone else? Yeah.
For folks that do DBS, is their medication typically go way down, a little down, or not at all?
Yeah, so that GPI target, that big target that's easy to hit, you can reduce the medication, but not as much as you can with the other small target called the STN. So if you're someone who has a lot of side effects from medication, then we might pick STN for you, because then you can more dramatically reduce your medication than you could with the GPI. Both of them, you reduce it, but STN, you reduce it more. Yeah.
With focused ultrasound, I'm trying to picture this hot ultrasound
Mhm.
burning a path through someone's brain.
Mhm.
Isn't it going to be burning some things we might need on the way to the spot in the center? And is it just one beam, or is it multiple small beams from all over? How does it work?
Yeah, so it's a bunch of beams that focus at that site that you want to burn the hole. So they basically come together at that point. So when they're crossing through the other stuff, they don't disrupt that. Yeah.
That's pretty important.
Exactly. The rest of the brain should be fine. The only thing is, you want to burn a hole that's like big enough to control the symptoms, but not too big that then you cause side effects. So that's also something that we're learning over time. How big should we make this lesion? And we're getting better at it as we've been doing it for longer. Yeah.
So with the closed loop system that the FDA just approved
Mhm.
for DBS, it's supposed to read the body and auto adjust. Are you definitely going to be adjusting much less since it auto adjusts?
Yeah, so the closed loop is interesting. They're basing it off of, for the Medtronic system, there's these little, like, they're called local field potentials or signals in the brain. And in Parkinson's disease, there's this thing called a beta band that gets way too high. And that is what actually we think causes you to not move well. So that closed loop system can sense when that beta band gets really high and then deliver a lot more stimulation during that time, but not whenever that beta band is normal or low. It's more kind of like researchy right now. I think it's going to be a huge part of DBS. You still will need to adjust it because you're going to have to also set, like, at what parameter do you decide is too high, right? And it might differ for everybody. Like, some people, you might have to add more stimulation for a lower beta band than somebody else. So it's going to take a lot of kind of figuring it out and working with it until it can kind of automate itself,
Okay.
But it's really cool. Yeah. Yeah.
Simply not working very well. Are there any very serious neurologic complications of DBS, such as incontinence or the like?
Yeah, so the complications of DBS that we want to think about are first in the acute setting, right? So when you have the procedure, there's somewhere between a 1 to 5% chance that you could have bleeding in the brain or a stroke during the procedure. Those risks are actually lower now because we've been doing this for so much longer and we're selecting patients better and we're better at it, but you have that acute risk. There's also a risk of infection. So that hardware that's in there could become infected. And that could happen acutely or later down the line. And those things could definitely affect bladder function and overall movement too. But if you don't have any of those big complications, bladder problems are not common with deep brain stimulation.
My
One more question, okay?
husband had DBS and was the 1% that had the brain bleed
Oh,
and developed incontinence both ends from it.
yeah.
But when they turned the DBS on 6 months later, after we went through all the therapies, it went away. Like
Good.
when the DBS turned on, I know it's not supposed to do that.
Yeah.
It did.
I know the brain's a weird thing. I'm not claiming to understand 100%. Well, that's good. I'm glad
You're
it
not.
was in the end a good outcome.
Actually, we do have time for one more. So anybody have a final question?
Yeah.
Do any of these treatments help tardive dyskinesia?
Yeah, so we do deep brain stimulation for other movement disorders, not just Parkinson's disease. We do it for things like dystonia, so too much movement, that cramping like I was talking about. And then we have done it for other, random kind of movements too. And we do see that if we stimulate that GPI, which is a Parkinson's disease target, we can suppress movements that are too much. We do it for tardive dyskinesia in some cases when we can't control it with medication, especially people who have tardive dystonia. Some people get so much movement that they actually have like an arched back and their hands are cramped and they're just looking and feeling terrible. Actually, DBS can help those people, but we try medication first.
All right, let's. Right, we are going to transition and get Dr. I call him Renzo. So we'll get him set up. Okay? He's gonna be right here. So after Dr. Renzo talks, we're gonna have another break. Snack is out, so Snack will be out, break after you talk with Snack as well. And then, we'll have another speaker and then I think another Snack. I lost what the two speakers and then another break with Snack, okay? Snack. Yeah, I'm going to try to get it. Okay. We're just getting, we still got a few minutes. I'm gonna call IT just.
Oh, she just. What I said. I didn't realize that.
Yeah. Yeah. All right, just bear with us while we get this. It's always the death of our.
That's what. So precise.
Right. No, that's all right.
Your whole head is lost.
It's part of the gift.
Well, we did the first. Okay. In the world.
Right.
Yeah. Oh, yeah. He did residency, and then so I think he's
Save this all.
the originator.
Yeah, I'm going to Marcus.
This one? Yeah, I like. There's one down on that.
Oh.
Program is so large. Yeah, so it's lots of stuff happening. Now they, little pockets are very.
I get it.
But it's over there, how do we put it here?
Yeah.
At Zoom, can you see the screen? I'm sorry, see the screen?
But she's.
Renzo, I think they can, because what it would be up there, so that's what.
Can you hear me?
I know. Oh, we're back on camera. So then till then, even though
Hi,
Changed during the.
can you hear me well? Everybody? Okay, no microphone then, is that okay? Or yes, microphone?
Your choice.
Can they hear me?
You guys hear them on Zoom?
Yeah.
No?
I think so.
Okay. All right, hello again. I'm gonna try to go through these because I know that I'm the only thing standing before you and the snacks outside.
Microphone.
Okay. That better?
That is.
Okay, I have to modulate now my voice. Oof, I went too much. Here. Yeah, so I'm just gonna go over a few things that I always hear in clinic from patients that they talk about levodopa. Sometimes they're afraid of using levodopa, so I'm gonna try to go over these problems. But first of all, we have to start with a little bit of history because I love history of neurology and especially history of Parkinson's disease. So everything started back in 1817 with James Parkinson. So that's where all of this started, with a description of these 6 patients in his manuscript, An Essay on the Shaking Palsy. But it wasn't until like almost over 100 years later that we first identified in 1960 that there was a lack of dopamine inside the brain, okay? And a year later, we started doing trials to give dopamine to patients with Parkinson's disease. It was intravenous dopamine. And at that time, it was just pure dopamine and levodopa without that carbidopa. So patients were having terrible side effects, okay? So it took a while, and even in 1961, they say, you know what? This is not going to work. Throw away the option of using levodopa. So we're close to never having levodopa for the management of Parkinson. And it wasn't until 1967 and then George Kotsias, he came up with the idea, okay, let's start with a low dose and now we're gonna build it up. Okay, again, this was with only levodopa, we didn't have carbidopa, so but he was able to have patients take the medication, tolerate the medication, and have dramatic response, dramatic improvement in these symptoms. And this was published eventually, and that's where everything started with the management of Parkinson's disease and levodopa. He was using as much as 16 grams of levodopa a day to treat patients. Just think about that. Most patients right now take somewhere between what, 300, 600 milligrams, not even 1 gram of levodopa. He was using 16 grams to be able to have patients respond to this. This is George Kotsias. So then what is wrong with levodopa? Okay. And you are going to tell me, have you ever heard of this? Have you ever heard that levodopa is actually damaging the brain? That could damage. Anybody has heard that before?
I
Okay.
heard it builds up a toxicity
Yeah.
in your body and causes dyskinesia.
Okay, we're gonna get to that. Has anybody heard this, that you should delay as much as possible taking levodopa?
Yes.
Yeah.
That's a common one.
Yeah.
Yeah. How about this? That you lose the effect of levodopa.
Yeah. Heard
Yeah.
that.
And that levodopa causes dyskinesias. Yeah. Even we talk about it, we say levodopa induced dyskinesias. Okay. But it's all of this truth. Is this how it works? So we're gonna go over each one of these quickly and see what the science tells us about it. So let's talk about it if it's really toxic to the brain. Is it toxic to your body? What would you expect if a medication is actually causing more damage? Are patients gonna survive more or less when they're taking levodopa?
Less.
Yeah, you would expect that they're not gonna have a good survival if they're on medication. Oops, we went the other way. Oh, why is it? It's going in reverse. There we go. There. So what we actually see is that patients live longer when they are taking levodopa. So we actually increase their lifespan if they're treated with levodopa. Okay. Now, okay, they live more, but maybe still causing some damage. So you would expect maybe they have more disability, maybe more symptoms of Parkinson as the medication is actually damaging. But no, we actually see that patients have actually better quality of life and less disability on the medication. And then these problems that we see with Parkinson, we found out that it's not really related to how much medication you're taking, but are related to how long you've had Parkinson's disease. Okay. But maybe we cannot really see the damage on the symptoms, but we can take a look at the brain itself and see, okay, are we damaging the brain? And there's a few studies looking at that, and we know that the substantia nigra actually has no difference on pathology in patients who are taking levodopa or not taking levodopa. And another study looking at really how much medication you've taken throughout your life. Okay, and they separated patients depending on how much levodopa throughout their life they were taking. And you would expect that if it's really toxic, it's going to be damaging the brain. But then when they look at the brains in pathology, there wasn't any of that damage that you would expect. But the more levodopa you've taken throughout your life should have more of the damage and changes in the brain than without taking it. Okay, so I think that with these studies and this evidence, we can finally say that levodopa is not really toxic to the brain. Okay, and it's good to hear that that was not much of what you have heard. So probably it's already fading into history. This there. Okay, this is the one that a lot of people has heard of. You should delay. Why do you need to delay taking levodopa? Anybody?
So you don't get dyskinesias?
So you don't get dyskinesias, okay? Anything else? Because you lose the effect, so you want to save it for later? Yeah, okay.
Want to say you take medication.
Because you don't want to take medication, maybe. Right. Yeah. And then that could be a fair reason. It's not really related to the levodopa, but the other two are inherent to the levodopa. You don't want to get those dyskinesias. You don't want to lose the effect, so you want to save it for when you really need it. Okay. But what do we know is we can take a look at this graph, and you have divided three groups there. The first one at the top is the patients who started early with levodopa. Okay. Then the second group is the patients who started delaying levodopa, but taking other Parkinson's medication. Okay. So those are your MAOB inhibitors, your dopamine, so like rasagiline, selegiline, Requip, Mirapex, those medications, and you delay as much as possible to start taking levodopa. Okay. And then the third group is the patients who decided, you know what, I don't want to take any medication. They hold them as much as possible. They didn't do anything until they start taking levodopa. And I don't know if you can see where is the start of levodopa for each of these groups over there. But at the end, what we're looking is, if we're looking at the onset of dyskinesias, this is a timeline of how long they had the disease, how long they had Parkinson's disease. And if you look at the three groups, they all started having dyskinesias roughly about the same time, okay? But the main thing that came out of this is over here, hidden on the side, how much disability burden they have throughout these years, okay? The higher that tower is, the more disability these patients have, okay? So the patients who started early, they had much less disability than the other groups, because the other groups were just struggling with their symptoms, holding on not taking the medication that we really consider to be the best to manage the Parkinson's symptoms, okay? And especially the holding on taking any type of medication, those had the highest disability. So in general, we don't say to hold medication. We actually favor starting medication and starting early with the medication can be helpful. It can reduce your disability. Okay. Oops. So the next one we're going to talk is how about the effect of the medication. We're losing the effect of the medication, isn't it? So what happens really is that this is how, as the disease progresses, how the medication is going to work, okay? So that deep blue that we have in the middle is our therapeutic window. What do we mean by that? It's the area where you're gonna be the best, when your symptoms are gonna be well controlled, where you're not gonna have side effects from the medication, where you're not gonna have the symptoms of Parkinson. The pink or reddish in the top is the side effects, okay? And lower you're gonna have when you're off, when your Parkinson's is not well treated, when you're having your symptoms of rigidity, slowing down, those tremors that are affecting you. So at the beginning, we have a big window to treat patients, okay? We can give the medication and chances that it's gonna help them, regardless almost of what dose we give. We can take a small amount, it's gonna help, and even if you take too much, chances that you're not gonna develop those side effects. But as time goes by, you see that window starts to get shorter and shorter. So now, what if we put there a curve of what the medication that you're taking? And that's what is going to happen. You see at the beginning, you take the medication, goes up and down, and you're staying within that window of treatment. But then as the disease keeps progressing into a moderate to more severe symptoms, every time you take your medication, you're going into that pink and you're going down into the light blue. And that's when we start saying, oh, the medication has lost its effect. The medication is not working for me. But it's not that the medication has stopped working. The medication is working. But your window of help has shortened because of the progression of the disease. So your ability to handle the medication is much different at the different stages of Parkinson. And we can see that if we break down into each single dose that we're taking. Early in the disease, we take one dose, and that dose can last for 6, sometimes 8 hours. Okay? Then for the patients here that had Parkinson's for a long time, you probably remember at the beginning you were taking maybe 3 times a day, and that was great. You didn't have any wearing off. There was no problems, but then over time, that dose starts to shorten. And now the medication only lasts you maybe 4 hours, 3 hours. And in the more advanced, eventually it's gonna fall into about 2.5 hours window. And the reason is that if we look at the pharmacodynamics of levodopa, that's how much it lasts in your system. We give you levodopa and we measure the levels on your blood. In 2.5 hours, those levels are gone. But the ability of the brain to take that levodopa, keep using it for later, okay, changes as the disease progresses. So at the beginning, you can use more of that levodopa. It will last you 6-8 hours. But the more dopamine neurons that you're losing in the brain, then your medication is just not gonna last. You're gonna use it, everything immediately, and then it's gonna be gone. And that's when you start having all of these side effects and the dyskinesias. Or your symptoms are just not gonna be well controlled, and it's gonna drop down into that off period. But regardless, all throughout the disease, levodopa is still working, it's still helping. So it never really loses its effect. It's just that, unfortunately, we're dealing with a progressive disease. And we just need to manage that as time goes by. Another topic that everyone is concerned about, the dyskinesias. The levodopa-induced dyskinesias. Now the question is it really that levodopa is gonna cause dyskinesias? We use levodopa for other diseases, restless-leg syndrome, for dystonia, sometimes even for just essential tremors. Do they develop dyskinesias? Has anybody ever described dyskinesias in these patients? The truth is that we don't see dyskinesias in those patients. But what happens with Parkinson's disease? Okay, and again, these are studies looking at patients who started early with levodopa and patients who were delayed on starting levodopa. Okay, and if we look at when they start developing dyskinesias, we can see that in that first group, the first line, they start taking levodopa, that's that deep blue. They have many years as the disease progresses, they're being helped by this medication. And then it's later in the disease that they start having these problems with the motor fluctuations and then later dyskinesias with the darker red. But then patients who delay taking levodopa, but they're in the same kind of like years of progression, they start taking levodopa and very quickly they start having the dyskinesias. Very quickly they go to having these motor fluctuations. And even if we try to adjust for the amount of those that they're taking, we see the same result. That is, it's not related to just taking the levodopa, but it's how long you had Parkinson's disease and how the medication is affecting the brain and how you're handling this medication to cause the dyskinesia. Yeah.
So I wonder about that because
Yeah.
My brother is in a facility where he had a new caretaker and she was overdosing him on I want to say the slow acting carbidopa. So he was getting an extra pill. And the only reason I knew she was doing this is he came home and he was twitching. Okay, he had major tardive kinesia. I mean, like this. So that's, the medication was doing that.
Yes. I'm not saying that the medication is not gonna do it, but
Finish saying it's not the.
but is the medication in the diseased brain. The brain of Parkinson's disease, oops, I click. Okay, we'll try to get to it in a minute, but then what I'm trying to say is that the way the brain is gonna be able to handle levodopa is different from the early stages to the later stages. Early into the disease, if the medication itself, just by itself, is causing the dyskinesias, everybody would have dyskinesias from the beginning. But patients don't develop the dyskinesias until later in the disease. So that's what I'm trying to explain. That is, it is caused by the levodopa, but it's only caused in that diseased brain. We don't see dyskinesia in somebody who does not have Parkinson's disease.
So is it because of the progression itself that's gonna eventually do that anyway?
Exactly. So it's because of how long you've had Parkinson's disease and you're taking the levodopa that patients develop these dyskinesias.
I had a friend who was probably close to 20 years into the diagnosis, and for whatever reason, she was advised to take like one every 90 minutes. And she had such severe dyskinesias. She could not sit on a couch or anything. She just wiggled right off. And they cut back the levodopa and it got better. So she has the diseased brain, but she was also ODing on the levodopa.
And that goes a little bit to the previous slides when we're talking about that window that we have to treat Parkinson's. So our window is much shorter. So patients who sometimes they've been taking X amount for years, but then now they start developing dyskinesias, and then they haven't changed their medication. It's their window of treatment that is shortening because of this progression of the disease.
Someone asked to differentiate
Yes.
between dyskinesia and tardive dyskinesias.
Yeah.
That might be the confusing part.
Yeah, so when we talk about dyskinesias in Parkinson's disease, yes, it's these wiggly movements that we have, kind of like when you see Michael J. Fox. And when we're talking about tardive dyskinesias, it's very specific to medication causing some of these movements. But tardive dyskinesia can present not only with the wiggly movement, but it can present in other forms with dystonia. But it's usually related to specific medications that we know cause that are blocking dopamine in the brain to cause these movements.
So I'm just curious, if you get up to the point where dyskinesia is a problem, a real big problem, can you throw in some Ingrezza and have it taken care of?
There's many things that can be done. So another thing that to keep in mind is, are dyskinesias bad? I know everybody is afraid of dyskinesias, but are dyskinesias necessarily bad thing?
Ones I saw were.
It can get bad. It can be to the point that it's gonna affect your functioning. Okay, but having some dyskinesias sometimes is good for the patients. The medication is working, they feel better. Okay. They prefer having a little bit of dyskinesias than being rigid and slowed down by Parkinson. So I think that sometimes there's a lot of fear to dyskinesias, but some dyskinesia is not necessarily bad. When the dyskinesia affects your daily function, then yes, we need to do some things. And that's when we start making adjustments to medication, adding something to help with the dyskinesia, or like what Dr. Higginbotham was suggesting, doing deep brain stimulation or duopapan to control those dyskinesias.
Again, my husband had DBS. He's barely 4 pills a day now. He had DBS 2 years ago. He's been diagnosed for 17 and a half years. Is he doing himself a disservice by taking so little levodopa at this point?
No. No, I think everybody's a little bit different. Everybody's situations is different, but no, not, he's receiving treatment. He's receiving treatment in two different ways, medication and stimulation.
He doesn't seem to even need the medication though. If he misses, he doesn't no symptom.
The other thing is that to kind of go over a little bit more on this point is that if really the dyskinesias were directly related to just the medication, we would expect to see some dose dependence on that, meaning that the higher we go up, also we're going to see more dyskinesias all the time, inevitably. Okay, and that may happen with what we're doing, pulsatile dose of medication, but in a recent study looking at the subcutaneous pump, okay, we see that patients who were on this subcutaneous pump, that's the graph that is the line that is on the top. That's the average dose of levodopa they were taking throughout the day compared to the ones that were taking medication. Okay, so patients who are on the pump, much higher dose than the patients who are taking oral medication. So we would expect them to see more dyskinesias, but then when making the analysis, we see that they have less dyskinesias than the patients who were on oral medication, just through the pump. Almost 1 hour less of dyskinesias. Okay. So again, it's how your brain is able to handle the medication at different stages of the disease. In this case, with the subcutaneous pump, what we're trying to achieve is micro doses, but constantly throughout the day, instead of this pulsatile way that we are doing now when taking the oral medication. That creates more higher peaks on the medication, going into that pink zone that I was showing before and causing the side effects.
Can you offset your loss of dopamine with excessive exercise?
So that's another whole topic to discuss. But the main message I want you guys to take today is that despite all of these myths that we think of levodopa, despite of thinking, okay, we need to hold on medication, we need to delay it, or being afraid of the dyskinesias, is that there is science behind it to tell us that really, one, it's not just the medication itself, but it's how the disease is progressing over time, okay? And then overall, if we start with medication early or treatment early, you're gonna do better on the long term.
Is there a difference in treatment for Parkinsonism?
So again, another very broad topic to discuss. So Parkinson's are the diseases that cause Parkinson's symptoms, okay? And so that the rigidity, the stiffness, most of these patients are gonna have Parkinson's disease. That's the requirement for Parkinson's, that you have Parkinsonism. But there's a group of patients that are gonna have other diseases, and unfortunately, those do not respond to the medications in the same way. That's kind of like a way we differentiate one from the other. We are, okay, do you respond or not to the levodopa? And if you don't respond, that's when we start thinking, oh, maybe we're not dealing with Parkinson's disease proper, maybe we're dealing with some of these other diseases.
One more question.
Is there such a thing as a maximum dose, carbidopa, levodopa?
I don't think so. I think it all depends on balancing, like I said, side effects and how much is in helping you.
Are you going to talk about the difference between the pump and did the Cordia deliver it manually and the pump, you have it in you and you just make it come out with squishy on something?
No, we're not talking today about the pump. The pump is still in review by the FDA, so we don't have all the information yet.
Oh, it's not.
It's something that we're waiting to see what will happen, but it's kind of like an insulin pump. So it's a delivery of the medication constantly through a small needle in the skin. Okay.
All right. Can we give a round of applause, please? We're going to take a break right now. 15-minute break, I believe, right? Is that what it says? Okay. 2:45, come on back down. Snack is outside, go to the bathroom. Okay? There are some more bathrooms down the hallway the other way if that bathroom is occupied.
It's not.
That was.
It's okay. I mean, it's all right for the right person.
Yeah.
If it happens. No, I'm not against
I heard them say Montclair.
Yeah, it's gotta be the right person to let me know what they're getting. Like this guy with the void. Really.
Right, right.
And I get that. He's, you know.
All right. Pardon my food in my mouth.
We're
We're gonna get started for our next session. It is Dr. Philip Lee. He is a fellow in the neurology department at UVA. He is going to talk about new therapies, on what's on the horizon. All right, go ahead, take it away. He's got a microphone, so hopefully he doesn't scream like I am right now.
Thank you. All right, so my talk is a little different, if you can't tell.
Ninja Turtles.
I have a couple of questions to start off with. I like to be a little bit conversational when I'm talking. So who here knows who the Ninja Turtles are? All right, great. So we have some people who know who they are. The other question, who has ever heard the term research pipeline? Okay, so a little bit less, but some people. So a lot of times when we are thinking about research, we think about a research pipeline. So there's a lot of research getting started, there's a lot of research underway, and a lot of research coming out. So this pipe that all the research is going through and is coming down the research pipeline. I really enjoy research. Prior to med school, I did biomedical engineering, which was all about getting FDA products approved. And I did some drug research before that. So I enjoy looking up these research studies. And even for me, it gets monotonous at times. So I thought if we're going to do a presentation about the research pipeline, we need something to break it up to make it a little bit more fun. So I tried to think about things that are related to a pipeline, and there's not a lot of great things. There's things like rats and sewers and things. And I said, the Ninja Turtles, they live in the pipes. So
Better than rats.
yeah, the Ninja Turtles and some other turtles are going to join us throughout the presentation today as we talk about therapies in the Parkinson's disease research pipeline. All right. So what is the research pipeline? So this is the basically the process where a drug or product comes from an idea to being a product on the market. So there's a few steps to this, and we call them phases for the most part. So a phase 1 trial is when you have a new idea, a product that they want to test out. So you take a very small group of healthy people and see if it's safe, if it causes any problems in those healthy people. Phase 2, they take a larger group of people and see if it's safe in that larger group of people, assuming it passed phase 1 and was safe for the first part. And if it passes phase 2, it goes on to phase 3, which is the big clinical trials that we think of that are massive. And they are looking to see if the drug actually works. This is the part where we find out, is the product a Ninja Turtle or is it just a regular turtle? All right. After the phase 3 trial, if it's successful, if this product works, they apply to the FDA to be approved. And there's some back and forth there where the FDA maybe rejects them, sends it back, and they work out details. And then after the product's actually in the market, they call it phase 4, where they just watch the data as it's coming out to make sure no problems are coming out once they actually start using the drug. All right, so this is a image that came from an article last year. You can't quite see the whole thing, but these are all, not all of, but a lot of the drugs and things that are under investigation for Parkinson's disease right now. It is a lot of stuff that people are looking at for Parkinson's disease. So we're going to look at some of these today. There's going to be a lot of data, a lot of things that we talk about. What I want you to take away from this talk is basically what are some cool things that are about to come out on the market, and then what are some like really neat research ideas that are years down the road that might be part of Parkinson's disease. If you look at the top of the image, it says DMT. It means disease modifying therapy. Those are drugs and products that are meant to actually stop or slow down the progression of Parkinson's disease. So those are things we're looking at for that. On the bottom, it says ST, which stands for symptomatic therapy. So those are drugs and products that are meant to help treat Parkinson's symptoms. The little circle in the middle is phase 3, those big trials that are going on. Phase 2 is in the middle circle, and then the outer circle is phase 1. As you can tell, there's a lot less in phase 3 because most products don't make it through there. So I think about, when I see all those drugs on the outside there, I think about like all these little sea turtles going to the ocean, but unfortunately, most of them aren't going to make it. So we are going to focus on the big sea turtles, the ones that are thriving and swimming, the phase 3 ones, and see if they succeed. All right, so on to the actual topic here. Symptomatic therapies in Parkinson's disease. I was trying to find a good picture for this. This is actually AI generated. So some turtles with their symptomatic therapies here.
Very well done.
All right. So we just saw this slide in the last presentation. Mine's not as neat because I made it myself with shapes and PowerPoint. But as Parkinson's progresses, that therapeutic window narrows. So we're going to talk about symptomatic therapies first. And the first thing we're going to talk about is dopaminergic therapies. So all of these dopaminergic therapies are going to try to straddle this line where they treat your Parkinson's symptoms without causing dyskinesias, without causing those side effects. Because if the dose goes too high, you're going to have those dyskinesias. And if it's too low, you don't have treatment of your symptoms. So we want to be in that green space in the middle. And as Parkinson's progresses, it's harder and harder to stay in that zone. The first drug we're going to talk about is called IPX203. When we talk about these drugs, there's a lot of letters and numbers that are used to describe them. That's because all of these companies are coming up with so many products. Most of the products don't make it. They don't actually name and brand a drug until it is about to hit the market. Usually these letters stand for the company and the numbers kind of stand for what agent is in their line. IPX203 is coming from the maker of Rytary. Rytary is about to come off patent soon. So this is the new drug they're coming out with. It's very similar to Rytary in a lot of ways. They've made a couple of changes to the medication. One is they switched from IR little capsules in the tablet to IR granules. So that product, the purple one on the left of your screen should dissolve faster. So the medication should work faster. And on the right side, it has these ER beads. And the change to that part of the medication is that it should stick to the intestine and last longer, be absorbed more. So the idea is that compared to Rytary, this medication should work faster and last longer. And the reality, the data I've seen is maybe you get about another 30 minutes out of it. So it probably will be a good drug, not a market shaker. I don't, well, maybe say about that, but probably shouldn't say that. But it's going to be a little bit better, I think, than Rytary, but not a lot better. We'll say it that way. So they are not quite yet approved. They resubmitted some safety data to the FDA in February, and they are hoping to launch this drug in the second half of this year. All right. So what this drug would do, since it lasts longer, you basically have to, well, not have, but you would reduce the number of doses that you have to take and hopefully spend more time in that green zone. All right, this is the next kind of most exciting product that's coming out. So this is subcutaneous levodopa. So this is levodopa that gets injected by a pump under the skin. So this is a very exciting product. There's two different products kind of late into the FDA process. One is by AbbVie, is ABV951 Produopa. So this injects levodopa under your skin 24 hours a day. And their research studies, they showed about 3.5 hours of more good own time per day. So that's time that you're either not off or time that you're not having dyskinesia. So an extra 3.5 hours where you feel good during the day is what the initial data was showing. They were rejected by the FDA, March of last year, wanting more information about the pump. The actual question, basically, these pumps are causing a lot of skin reactions, where the injection's going in, so they're trying to get more safety data about that before they actually approve one of these pumps. So that's kind of held up waiting, see if we can sort out that safety data to get approval. But these could be in the market pretty soon. The other one, ND0612, is Neuroderm. Very similar product, very similar results. They just completed their phase 3 trials and they have not yet submitted to the FDA, but hopefully we'll see results of that trial and they will submit to the FDA pretty soon. All right, here's another pump. This is coming from Supernus Pharmaceuticals. So this is the apomorphine pump. This is a dopamine agonist instead of levodopa. Same concept of how it gets injected into the skin, potentially some more side effects with the actual medication they're using. This is already available in the UK and Europe. It hasn't been approved in the US yet. It's different companies there. This particular product got rejected by the FDA actually just this week on Monday, the third time they got rejected due to concerns with product quality. So they'll keep working on that to see if they can sort it out. And this could something that could be in the market in the near future if they are able to work out the quality issues.
Is there a limit to how many times they can submit the same medication?
Not necessarily. If it's a problem that's not fixable in a research study, then eventually the FDA will issue a hard no. This is rejected.
How long have they been in use in Europe?
I don't know the answer to that. Unfortunately, I don't know if anybody else does. But it's been for a while. This medication has had more trouble in the US from like side effect history than Europeans have been more accepting of it for the actual apomorphine itself.
What kind of quality issues?
What's that?
What kind of quality issues?
I don't know. The FDA didn't say that in their response, so that's not been publicly made available.
Do you know if it's since it's a 24-hour medication, is it supposed to help with sleep?
Potentially for somebody who is possible. But if you have a lot of symptoms overnight that normally respond to levodopa, then it might help them. I don't think that's one of the criteria they were looking for. They mostly looked at awake hours for the research.
We've used a dosage in the middle of the night. In other words, keeping everything every 4 hours in order to make it easier to be able to sit up and stand up and walk. And is that a good thing to make a regular thing in order to have every day be an easy time?
I mean, it depends on, that's going to vary very widely from person to person. On whether they should have overnight medication or not. With this pump, people would be getting the same or potentially getting the same dose 24 hours through the day. So it may be very helpful for that, and we might actually learn more about that once these products hit
Just
the market.
reach over and pump it instead of having to make sure the glass is full of water, make sure you have enough.
And these will all inject automatically. There's usually buttons to press for an extra dose, but it's like it just continuously injects. So the idea here, you basically make a flat line, you have the same dose over time. In reality, a lot of people, these lines probably cross so that you make it dyskinesias before you even get treatment of your symptoms. So it's not perfect, but theoretically, you could have a really good result with this, and you're not swallowing medication. So those people who have a lot of nausea, they could still get some with it, but it might be less. I don't have the data for that. But potentially a lot of benefit to these medications if and when they get approved. All right, so those are our symptomatic therapies that are very close to the market. So next I want to talk about disease modifying therapies. So these are the therapies that can slow down or stop the progression of Parkinson's. That's the idea behind them anyways. These are not nearly as far along, so I'm going to show you some phase 1 and phase 2 products here during this part of it. We also have another AI generated image here. This is turtles lifting weights and playing golf is what it came up with. All right. They put the ninja, I don't know, I guess those are like weightlifter outfits, not even ninja outfits. So anyways, going on to the actual products here. So probably the farthest advanced product is Anatap. This one is a small molecule. The idea behind this is that it binds to this iron binding site of microRNA. You don't have to know all of this, what I'm saying right now, but the idea is that it stops your body from making as much of the alpha-synuclein that's bad. And ideally, you would have less of that neurotoxic protein and potentially have less progression. That's the idea of this drug. So there is kind of slight improvement in the Parkinson's disease rating scale and in cognitive scores in its phase 2 trial. It just completed phase 3 trial, December 2023. The data is not published on this yet. They have not yet submitted to the FDA. So we don't know what that data shows and if it was successful in actually showing any benefit for the symptoms of Parkinson's or not. But this is probably the farthest along of the disease modifying therapy. So it's still exciting that there's something in the works, and we'll find out soon if it's going to be successful. Yes.
How was that delivered?
This is oral medication, I believe. Correct me if I'm wrong. I'm pretty sure this is just a pill. Yeah. Okay. All right, the next category of disease modifying therapies is antibodies against alpha-synuclein. So all these kind of pictures that you're seeing here are the alpha-synuclein Lewy bodies that characterize Parkinson's disease and Lewy body dementia. So there has been a lot of thought to create antibodies that can clear these abnormal proteins out and maybe help reduce the progression or reverse the symptoms of Parkinson's disease. They've been a little bit troubled. In particular, these types of therapies, most of the studies have looked to see if they can reduce the alpha-synuclein that's there, but we don't even know if they reduce that alpha-synuclein, if that will help slow progression or if it will reverse anything. There's just a lot we don't know here. So I just put 4 products that are down there. That first one is in phase 2 that's going to complete in November 2026. So that would, if that one were successful, we're talking 10 years down the line before we would start submitting to FDA probably. And there's, or maybe not that long, but UB312 is actively recruiting for phase 1. And the other 2 I put down there don't even exist. Well, they're not in the process anymore. They've withdrawn, so they didn't work. So I put those up there just as examples that, a lot of these are not successful and the companies are pulling their studies. Because they're seeing that even in the early safety process evaluation. So we'll see if anything comes from those particular agents. One of the other big products out there is these stem cell therapies. So there's 2 ideas behind using stem cells to treat Parkinson's. So one idea is that you take stem cells, which are cells that can become other kinds of cells. So there's 2 sources for those. You can take them from the patient themselves, or you can take them from human embryos, and you can do one of 2 things with them. You basically take those cells out of the body, you get them to turn into other kinds of cells. So there's 2 kinds of cells that they try to get these stem cells to turn into. One is dopamine neurons that you lose in Parkinson's disease. So they try to turn them into dopamine neurons and inject those back into the brain and the part of the brain where they're lost. So that's one theory of stem cell research. The other, they take those cells and they turn them into cells that produce all these chemicals to help neurons survive, and they just inject those into the bloodstream. The idea is that those cells will make their way to the brain and produce chemicals that help your own neurons stay alive longer and slow the progression of Parkinson's. So those are the 2 ideas behind stem cell therapy. There's a few trials out there. Sorry, cut off a little bit there. But as you can see, these are pretty early. So 2 of these are from Texas, one's from China. The first one's from Texas. This one completed a phase 2A trial. This was stem cells that they basically took from people's bone marrow, I believe, trained them to produce chemicals to protect the brain, inject them back into the bloodstream. I don't know if there's any plans for a phase 3 trial. This one or not. Couldn't find that. The next one is a product that's currently in phase 2 in China. So this is basically where they take stem cells. I don't know the source of the stem cells for this one, turn them into neurons and are injecting them directly into the brain into the place where they want them to go. The last one's another one in Texas that they're infusing the patient's own stem cells. Also in phase 2, that one's actively recruiting. The next kind of category of drugs is genetic therapies for Parkinson's. So this is going to be drugs to treat genetic forms of Parkinson's disease. So the first one here is BIA 286156. Hopefully they change the name before they that slide is really small, but the idea is that basically for patients who have GBA1 mutation in Parkinson's disease, they have decreased function of that enzyme, that's little red box there. And because that enzyme's not functioning well, it creates toxic chemicals and your cells die. And so this is a small molecule that helps that enzyme work better. It helps clear those toxic chemicals. And the idea is that this could help neurons survive longer for these specific people with this genetic form of Parkinson's disease. This is currently recruiting for a phase 2 trial that'll complete in July of 2026 for safety evaluation. We don't really have any data if there's any clinical benefit to it or not yet. All right, this is a similar kind of product. So BIIB122. This is for patients with LRRK2 mutation genetic Parkinson's disease. This is a different problem where this gene basically is working too much in creating toxic processes in the cell. So for this particular drug, it is a small molecule that people will take and hopefully inhibit all the processes that this enzyme is creating and killing cells. Yes.
How do you know if you're that
LRRK2?
particular
Right.
genetic?
Yeah, how do you find that out?
Yeah, so that's a great question. Most people don't know their genetic Parkinson's status. Probably, I mean, we don't know exactly how many people have a genetic component to their Parkinson's disease. We know there's a certain number of genes that contribute to Parkinson's disease, a couple of genes that are, you're almost definitely going to get Parkinson's, a lot of genes that put you at higher risk, and a lot of people with Parkinson's that we have no idea if they have a genetic problem or not. And some of them we've tested, some of them we haven't. We don't regularly test for the genetics in Parkinson's unless somebody has a really strong family history or they got Parkinson's really early in life, because for the most part, it doesn't make a difference unless we're kind of talking about family planning and whether people want to do special like fertility treatments to not have that risk of passing it on. And so unless that's part of the equation, we don't really do the Parkinson's testing. Once treatments like this start hitting the market, I think people will get tested very frequently because then it makes a difference for what we can do for you. So right now, most people aren't tested. But if it's going to make a difference in therapy, then I think we'll start testing people more aggressively for the genetics. All right, so this one is phase 2, scheduled to complete in December of 2025, and see what that shows. All right, everybody doing okay? This is kind of intense. So the next product here is gene transfer therapy. So these drugs both start with AAV2. That stands for basically adenovirus. And then the second part says GDNF or GAD. That's the actual gene they're entering. So these therapies use a virus to put a gene into your cells to basically help slow this progression of Parkinson's disease. So AAV2 GDNF, this is for a gene for a chemical called glial cell line-derived neurotrophic factor, which can help your neurons survive, is the idea. So this is a surgery. They take a needle and inject this into the brain and the putamen. That's what that picture is at the top of them doing this. It's a little small, but that's what they're doing there. And so it showed some benefit in animal studies and is active in phase 1 to see if it's safe in a small group of people right now. The other one is AAV2 GAD. So this is glutamic acid decarboxylase. So kind of the same thought that it will help these cells survive. So this one, they're injecting into the STN. That one's active phase 1/2. Kind of simultaneously, that's gonna it should complete in August of this year. So get some initial safety data on that one. These ones are still, these kind of therapies are a long ways off, and they will need a lot of long-term follow-up to determine the safety and efficacy, since they're actually changing genes in your body. But cool ideas that are out there, and maybe someday they'll have some success. All right, I added one last slide here. So therapy. So these are turtles doing physical therapy. This is what the computer gave me. All right, so I just have one thing here. Thanks to our dear physical therapist friends. I asked kind of what is exciting and new in the world of physical therapy. So there is one program out there that I just wanted to mention. So most people are probably familiar with Big and Loud. So this is kind of coming from the same people who developed Big and Loud. They have this gym out in Arizona, and they call it the Power program. So Parkinson's Wellness Recovery is what they call it. They say Power. So it's a lot of exercises that help with Parkinson's specific symptoms. So posture, weight shifting, things that are real motor problems in Parkinson's disease. So unless you live in Arizona and you're here for the day, then you probably won't be able to go to this gym on a regular basis. They do have some like retreats and therapy intensive things. I've never tried to send anybody to those, so I don't know how that would go. But the cool thing is they do have some kind of online videos, exercise videos that aren't too bad. So it's kind of like exercise videos that you could do at home on your own. So I think it's kind of cool, something other than medication that's out there, some new innovative therapy practices. So I just wanted to mention that and put it up there as well.
And local therapists are certified in it, and you don't have to go to Arizona.
Oh, great.
No, no, look, you can go to the website and it'll tell you who's certified in the area, wherever you are.
All right.
What's the website?
What's the website?
Yeah, I would just look for Parkinson's Wellness Recovery.
The logo there, just look for that, you'll find it.
PWR. Yes.
Is there any way that we can access your slides?
I don't know the answer to that.
So what will happen is the Zoom is being recorded right now, and it should have, when it's recorded, it should have the slides on there.
Will we be able to read them?
I hope so.
Real teeny?
No, that's all right.
Yes.
I was curious on some of these treatments that are guided towards making neurons survive. Would those really only be viable for people in early stages?
That's a great question. Are we going to have therapies that can actually improve symptoms for people who already have more advanced stages of Parkinson's? I don't know the answer to that. I think a lot of those therapies are going to be a little bit farther off. I mean, certainly some of these therapies are trying to put cells in. So like those ones where they take stem cells and put them into the part of the brain. There's not data that actually works yet, but if that does end up working, then that could improve symptoms for people who already have Parkinson's. Most of the ones that slow progression are going to have a lot more effect for people who have these disease course because we don't have a way to really regenerate neurons once they die at this point.
We got time for one more question.
Oh, it's all about the those are kids.
Yeah, these are my two older daughters.
Turtle.
Yes.
Anyone have a question?
The turtle theme was brilliant. Thank you so much for having me.
Thank you.
All right, we are gonna transfer over. Oh, you kept that seat nice and warm. One of the things that I am like, it gives me the heebie-jeebies. You wanna let Naomi know? All right, so Naomi.
We can still hear you, Sarah.
And
No.
other people.
All right. We have Catherine. Oh, I did actually just turn it off though. We have Catherine and Naomi here from APDA. They didn't get announced in the beginning when we did all the like drug reps and stuff, because you guys aren't a drug rep. But Naomi will be presenting on community resources. And I gave that to you. Have fun.
All right. Hello, everyone. Can you guys hear me okay?
Yes.
Okay, perfect. So my name is Naomi. I'm the program director for APDA Virginia. Here's Catherine. She is our chapter coordinator. So together we run the entire state. Shout out to Sarah for inviting us and partnering together to provide resources for the community. We're very happy to be here. So before I begin, is anyone familiar with APDA Virginia? Have heard of us, attended our programs or events? Okay, good. So this will be a brief summary of what we do at APDA Virginia. So a brief history about who we are. We started in 1993 in Richmond. Kathy Morton is our former president of that chapter. From there, we expanded to the Hampton Roads area. And as of 2 years ago, we're now the Virginia chapter. So we serve the whole state. So here's the staff. So we're a small staff of 2. The great thing about APDA Virginia is that if you call us, it'll be either myself or Catherine answering the phone. It's not a 1-800 number. We're very community-based, very oriented in the community or whatnot, and then here are our board members. So what do we do at APDA Virginia? So there.
Naomi, excuse me, could you turn your
Oh,
body so
sure.
you're not sending all your sound waves to the other side of the room?
Sorry, I'm trying to, okay, I'll look this way. Sorry about that. So there are 4 pillars that make APDA Virginia. So support, resources, education, and research. So in terms of programs, we help develop START support grants. So we are a statewide resource. So if an area does not have support groups, we help start them. We also provide referrals. So if anyone's newly diagnosed, looking for a support group in the area or in Virginia, we guide them in the right direction. We have 2 newly diagnosed programs. One is called the PRESS program, and it focuses more on your next steps following your diagnosis. So if you're still working, kind of navigating the mental health aspect, navigating what's next, the PRESS program is more likely for you. And it's great because it's very small in a very controlled environment. Sometimes it can be very overwhelming when getting diagnosed with Parkinson's disease. So we try to create opportunities or environments for those who are in the same demographic, newly diagnosed as well. Our other program is called Good Start. That's more so if you're focused on the medication management. So you're like, okay, I'm great mental health wise. I want to know more about Parkinson's. What should I be focusing on now? Exercise, healthcare routine. This program is more for you. So both programs that we have done, PRESS started yesterday. We try to do them twice a year. And then Good Start, we're doing one in Richmond, but we have done a virtual one before. So we try to do in-person programs as well as virtual programs too. Our other program is called Connecting Through Art. It's kind of like a sip and paint. We like to focus a lot of times on education, but sometimes on socialization as well. So we've had one in person in Norfolk, one in Williamsburg. We would love to have one here if you guys are open to that. But it's great because you get a chance to get out the house, meet new people. We have snacks, music, a great way to kind of get involved that way as well. We also have a financial hardship program. You can apply one time in a 12-month period on our website. That can cover anything Parkinson's related. So it can be medication, transportation, home modifications, anything Parkinson's related. We don't ask any questions. It's a simple application on our website. And then we are a statewide resource, as I mentioned earlier. So anyone diagnosed with Parkinson's disease and looking for a local resource, you gotta point them in the right direction, no matter what area they are in. So you can see the park is the Charlottesville location. So we also have numerous webinars that we have. So our next one in April is actually a doctor from UVA on meditation and mindfulness. We've covered different topics such as nutrition, driving, medication management, legal issues. We record them and put them on our YouTube page. So if you go to APDA Virginia on YouTube, all of our webinars are recorded as well. Last year we did a Raise Your Voice program. So it was a speech program that was also recorded as well, free of charge. and available to anyone who wants to focus on speech and Parkinson's disease. And then finally, Education Day. So similar to something like this. We've done one on DBS, focused ultrasound. We did one in Northern Virginia on medication management. And then, so we are a statewide chapter, but APDA is a national program or a national organization as well. If you go to APDA on our YouTube channel, there are several other programs that we have, webinars that we have. We did our virtual conference that was virtual earlier this year. So all of our programs at APDA are recorded free of charge, a great way for resources as well. And then we also have virtual events too. So any other chapters that are hosting programs, whether webinars, exercise and wellness events, there may be a time difference, but they're all available for free on our website as well too. So we recently had our first conference in Williamsburg. This was our first conference since COVID. So we're very excited about that. Over 200 people came. We're really excited to continue hosting this next year. Other resources that we have, literature are all free. If you visit our table, we have different topics such as nutrition, veterans and Parkinson's disease, medication management, constipation. They're all available free on our website, or you can get them ordered to you as well. And then finally, we are a one-stop shop for anything Parkinson's related. So any questions that you have, you're more than welcome to always call us for anything related to Parkinson's disease. We get questions all the time, emails, calls. Like I said, we're very community-based, so we pride ourselves on being able to ask questions related to Parkinson's disease to support you and your loved one. And then we are having our walk June 8th at the Warhol Sports Complex. I know it's a bit far, but this is a very big, important program for us. Helps support our programs that we do. So the conference, the financial support program that we have, new programs that we want to develop. It all goes back to our programs that we have for the entire state. So if you want to drive or have a satellite walk or still support us, we welcome the opportunity for any donations that you have. So finally, how can APDA support you? As I mentioned earlier, we are a one-stop shop for anything Parkinson's related. We have a newsletter that comes out every other Sunday. It's a great way of staying involved with what we have going on in the area. All of our programs are free, whether virtual or in person. Looking for a support group, we're able to point you in the right direction, and you can attend any of our community events. Also, if you're free, following this program, we are doing a World Parkinson's Day, Pints for Parkinson's at the Darden Market. So we hope to see you guys there. And that is it. Any questions or anything for me? Yes.
So you said that you have connections with the VA. So I have several veterans that I'm director of operations for a home care agency. And I have several veterans that have VA benefits, but we have not been able to break the code of VA.
Okay.
Is there someone in your agency that could help them get their personal care hours covered?
I have your email, so I can email you after. I know a person at the VA. I'm not sure what the process may be to kind of collide those services, but I can point you in the right direction.
That would be great.
Seen several of the APDA webinars and other organizations, Davis Finney, Michael J. Fox, and so on and so on and so on. Do you all coordinate anything, or you're basically on your own, or do you consider yourself in competition, or what?
I wouldn't say we're in competition. I mean, we are different organizations, but we welcome any type of partnership. We, advertise any program, local nonprofits. We may not advertise like PF or whatnot, but we don't consider it competition. We work with anybody in the community. So. Any other questions? Yes.
If you are a member of the park, we have plenty of APDA stuff at our gym. So if you're looking for any of the pamphlets or booklets or anything, if you didn't get anything here, we always have a stack full of stuff there. Okay?
Yes.
Do you do any lobbying on the national level?
So we're actually in talks of doing some sort of advocacy in the future, maybe like next month. So we're trying to figure out whether it be like a Virginia Congress with other local nonprofits in the area doing some lobbying or some sort of advocacy. National wise, you know, because like I said, we're a local chapter, but we're looking to do more throughout the state with other local nonprofits for doing some type of advocacy.
A couple of people who are here went down to your Williamsburg thing, including myself.
Yes, yes. So I'll most likely I send Sarah all of our programs and events. So if you see email from her for a Good Start or Press, we're welcome to have you to any of our programs that we have. So. Well, thank you so much for allowing me to be here today.
All right, so we are gonna have a bit longer of a break. Keep grabbing one of these papers, putting it down and forgetting where I put it down. So you're gonna start our break now, which is about 10 minutes before than what we originally planned. So come back around 3:50. That's 20 minutes, plenty of time to go to the restroom. Again, restrooms are there. There's also some down there. Snacks are still out, okay? Go have fun. We're gonna meet you guys at the Zoom.
There's also another restaurant.
Okay, we're having a break right now. We are just getting people in. We still got a couple more minutes. Don't be so suspicious. Don't be suspicious. Don't be suspicious. I think we're the only ones that should know that. So we did have some people leave, so you may have some empty seats next to you. We have one final push through, and then we will let you guys go for the day. I want to give a big shout out to Renzo and Hannah in the red. Hannah hasn't spoke much today, but she was also very important in putting this together. It was interesting, the way we got this started was, we had a board meeting, talked about wanting to do an educational event. I sent Renzo and a bunch of other doctors the information about the bingo night that we had in February. And then literally he emailed me, he was like, hey, I want to stop by the gym. We want an educational event. I was like, this is perfect, let's go. All right, so that's how we got started. So this next station. Okay, this next section is going to be taking control of the disease. We're gonna have a panel discussion, so there's gonna be a bunch of us up here, OTPTs, RNs, speech therapists, myself. That's mine. All right, so we're gonna talk about who we are, what we do, and then we will open it up for you all to have any questions about why and what we do. Okay, let me go ahead and bring them in. Ladies? You guys leave me?
They're off drinking already.
One of you left though. Melissa left. All right, so we can stand, it's okay. Well, you can sit.
Yeah, you can
Stand for a little bit. Does anybody know how to deliver a baby?
Ag bus? I know.
We should get a doctor.
Is there a doctor in the building? All right.
Done it 4 times, so I can do it. I can pull a chair, yours too.
So we also do have one microphone. So we won't split it up, we'll just talk really loud. So most of you all know, and I hope you know who I am, Sarah Lincoln. I am the president of the Parkinson's Activity Resource Center. We also do Rock Steady Boxing, which is the majority of our classes. We offer 17 of those a week. Certified in Rock Steady Boxing, also certified personal trainer, and certified in urban polling, which I did not bring today, but some of you all do know what that is.
I'm Lauren Berman. I'm an occupational therapist. I mostly work on the acute inpatient side at UVA Hospital, but I also work in the multidisciplinary clinics for both the comprehensive Parkinson's clinic and also the atypical Parkinson's clinic. So I do see a group of individuals on the more outpatient style side from like a consulting perspective.
I am Renee Bricker. I'm the speech pathologist in the Parkinson's clinic. I have been a speech pathologist for 20 years and have been working in neurology in our ALS clinic for the last 15 years. So I was really excited to be a part of this clinic. I think we're like often the lost therapist in the group of PT, OT, and speech. And speech therapy, of course, I think is very important because it helps you communicate more effectively, which can be the case often with Parkinson's. And we can also help you with swallowing problems if you start to develop any difficulty with your eating and drinking. I will complete swallow studies. And like Lauren said, we are sort of acting as like a base of knowledge for you and referring you out to people closer to where you live for actual therapy.
Hey there, and I'm Melissa, the physical therapist. So for physical therapy in the clinic, especially, we try to connect people with resources, local therapists or local exercise classes. And then just in general population, it's nice to get people hooked in with the physical therapy early so they can start to establish an exercise program and start learning things they can do early on. Like let's maximize your balance before it starts to get affected. So you're coming from a higher place. And so, yeah, so we hit that kind of stuff, teach people about exercise and what kinds are good.
You guys want to take a seat? We're just getting some feedback from the, from online. Oh, did I take your?
No, it's
Okay,
okay.
cool.
I could.
We are gonna play musical chairs.
You have to remember our names now when we change order.
Renee, Sarah, Lauren, Melissa. But thankfully, not too many Laurens in this group.
Yeah.
I guess I have a question to start off. How many people in here who have Parkinson's exercise or your care partner exercises? Okay. How many people go to a gym?
Excuse me.
All right. How many people have been told by their physician to exercise? How many people said, oh, I'm fine?
Well, that's my first question. I'm gonna start with these. I see patients that are like newly diagnosed, and I talk to them about, oh, why don't we set up some physical therapy? And the answer that I always get from the patient is like, why? I don't have any problems. And so that is harder to convince them. So what would you say for those patients that they say, oh, I don't have any problems? Why do they need to go to therapy?
Oh, to therapy then. Okay. Well,
You said the word.
I think the more you can get established with a therapist early on, the better, because as things change over time, you're gonna need maybe to intermittently go back to that person to help address new problems that have come up. And then also it's so important to get on an early exercise regime before you start having a lot of problems. We try not to be reactionary, like, oh, now I'm having trouble with something, let me work on that. That was kind of an older model of physical therapy. Now we try to really hit people before they're having a lot of problems to teach them how to keep things from happening or how to deal with them when they do happen.
So what's the latest research on how often you should exercise and what kind of exercises should you be doing to raise your heart rate and things like that?
Yeah, so there's kind of 4 types of exercise that ideally everyone's fitting in at some point. Those being stretching, strengthening, aerobic things that get your heart rate up, and balance, all of which are important. Depending on what level you're at and what else you're doing during the day, certain things may be more important than others if you're not getting those. But I think that the best research right now is that the higher intensity aerobic exercise where you're really getting your heart rate up and you're breathing up is what because that's what helps produce dopamine in your brain. So that's what really is the biggest bang for your buck. Like if you're only going to do kind of one thing. So we say trying to get to a point where you definitely can't sing, you can't really carry on a long conversation. You can say a few words, but that you're really working hard. So for a lot of people they say, oh, I go for walks, I get some exercise, but that's not really the depth of exercise you really want to be getting.
So should you be doing this 5 days a week, 7 days a week?
I think ideally at least 3 days a week for like a half an hour or so, depending on what you can fit in, obviously. Any is better than none. And then as far as what type of exercise, people always say, well, what's best? Is it yoga or Pilates or boxing or whatever? And I say the best exercise is the one you're going to do, right? So some people like dancing sort of stuff. Some people, like or hate whatever. They like biking. So it's about finding something that you can do and like to do, and then making time for it and making a plan for it. So it's one thing to say, okay, I'm going to do this 3 days a week, and then week by week, you just don't do that. So I think scheduling it like on your calendar, just like you would schedule a doctor's appointment, at the beginning of the week, I'm gonna look at my week and think, all right, maybe Tuesday is a realistic day and maybe Thursday, and I'm just gonna put on my calendar, 4 o'clock Tuesday and Thursday is when I'm gonna either exercise at home, do a video from one of these organizations that has online classes for Parkinson's, go to a gym, go to a boxing class. But I think the making a plan is key. It's not just being motivated, it's making a plan of how to make it.
I highly recommend people Yeah,
Really?
so much fun
Isn't
and great
the-
exercise.
In terms of what Dr. Jardan was asking, isn't it also help to slow down the progress of the disease? Wouldn't that be a motivator for someone to want to exercise?
It is. Again, especially that high intensity aerobic is what's
Biggest
really been studied.
Things to emphasize. So.
Yes, I agree with you.
And it slows down so many other things, right? You know, cardiac issues, for, you know, everything, but especially if you're dealing with such a neurodegenerative disease, I mean, slowing that down is really important.
I was in PT at UVA for probably, I would say about 2 years. And I really appreciated the one-on-one that we developed over that length of time. Then I got to a point where I felt like I wasn't really gaining anything, or everything that I could do with them, I could do at home by myself. And so it was sort of like, I need something different. And that's when I found parks. And what I appreciated there, what I do appreciate there is it was fun.
Fun and social.
Socialization's.
And probably the most interaction that I think everybody liked to be a part of was the volunteer staff. You know, they came in, they brought their energy into the group that probably just all by ourselves, we wouldn't have really gotten too much off the ground.
I think,
And you learn from each other.
yeah, as I say, another thing is when you are a part of a group exercise, they, I can't think of the word right now, but they check on you. I mean, they hold you accountable. Why weren't you at class today? Were you on vacation? Did you bring us anything back from vacation? Exercise during vacation, things like that. If someone's not in the gym for a week or so, they're like, what's wrong? Where are they? They'll call them and say, why aren't you at the gym? So making sure, like, having other people hold you accountable for keeping that.
Are you looking at me?
I'm looking at everybody. No, you're the one who brought up the questions. Lisa, you were having a question?
Just a comment. When I was first diagnosed, I kind of wish my neurologist had pushed exercising more. I mean, I was doing it, but I think I was in denial in that, oh, that's not going to happen to me. So for example, I don't need a speech therapist. I had an assessment. I didn't at that point, you know. So I know doctors can only do so much, but I wish there would have been more of a push to get this started now. Because even saying, you know, it's going to continue degenerating, I'm in denial. So
I think another thing is, and I know this from personal experience, like once you're diagnosed, like the doctor says, do exercise, the person will do exercise for 3 weeks and have a program and then stop. And then stop going, stop like, oh, I have other stuff to do. And then they go back to their neurologist and say, doctor's like, are you exercising? They start back up for a month and then they stop again. And so until you can get that schedule in your day or your week, you gotta stay with it. And you just can't do it for 2 weeks and then stop. And then do it again for 2 weeks, 6 months later, and then stop.
I'm surprised they stopped, Sarah, because usually people feel that much better once they exercise consistently for a period of time and they then own it.
But it wasn't like until like they were starting to, the progression of the disease started happening and the doctor kept them, you have to keep on exercising.
I think Melissa made a really good point, is to put it on the calendar, just like you do that doctor's appointment. I need to go tell my sister that.
And I think too, life can get in the way, right? So it can be hard, and exercise can be one of those things that's really easy to be like, oh, I can skip that today because I need to go do X, Y, and Z. But really making it a priority and having it scheduled and into part of your day, you know, something that you enjoy, something that's part of your weekly routine, it does make it a whole lot easier to stick with if it is higher up on the list of things to do and isn't one of the ones that can be easily pushed off or pushed to the side.
And from a caregiver perspective, my husband always used to complain, why do you exercise so much? But now he realizes that I wouldn't be able to help him move like I do
if I didn't exercise so much. I do at least 5 days a week, sometimes 6, sometimes 7.
Excellent point.
We had a neurologist speak, and the analogy he gave is if I could give you a pill that you take 3 times a day, that could reduce, slow the progression of Parkinson's, could increase your mood, could make your overall health better. Would you take it? And everybody raised their hand. Said I would. And he's like, great, 30 minutes of exercise 3 times a day. So.
Not 33.
I mean,
3 times a week.
3 times a week.
Yeah.
Sorry, not a day.
Before we had like electronic prescriptions, I used to like write on a prescription to my patients, exercise, and then they're like, you're gonna go home and you're gonna put this on your fridge, and that's gonna be your prescription for your treatment.
And I think sometimes a physical therapy referral can get people jump started too. Because I think, more than just doing it yourself to get started and maybe not knowing where to start. Sometimes just getting a PT referral where they can assess what are your areas of weakness? What are your areas of range of motion limitations? What is your aerobic capacity like? Then they can get you started, maybe not even for 2 years, maybe for a couple months until you're on a program that's appropriate for you that you can keep up with.
And I think a hard piece of it too is that you might know that you need to exercise. Deep down, you want to exercise, but it's getting started that's so hard, right? There's that kind of speed bump you have to get over because you just don't feel like it. So sometimes having another person or another, like those people to hold you accountable, whether that be your care partner, whether that be somebody that you met at a support group, whether that be in order to get yourself exercising, at least to start out with, we're gonna do it in a location that is more exciting. So I'm gonna go for a walk at the park instead of just around the neighborhood. Those types of things. It's really getting over that first speed bump and getting going that can be some of the hardest pieces of it.
Are there any physical therapists in town here that know specifically about Parkinson's that you could recommend?
Yeah, there's definitely, I've been referring people mostly to the UVA outpatient therapy at Fontaine, because there are a few neurologic clinical specialists there who work, who have a lot of experience with Parkinson's. It's hard to find someone at your average PT clinic that does a lot of neurologic focused PT. It's a lot of sports medicine kind of stuff.
And you can get prescription from your doctor specifically for the UVA clinic?
Yeah, and there's 2 portions to UVA PT. There's the orthopedics, which is at on Ivy Road at the new building, and then what's at Fontaine is the neurologic.
I also think that ACAC has got they're really developing a Parkinson's department, and they do have a Parkinson's PT.
They're talking about Ashton's.
All that involved at ACAC. And what they want is your membership.
But ACAC is part now of UVA. We have gotten Dalrymple has written a prescription. I was having trouble getting in Jay's medical supplies because if we had hospital and rehab and home health, I wasn't able to order while have you had your thing for in the last 30 to 60 days, home health? Yes, I have. Well, then you can't order them by yourself. And home health was not ordering the supplies for me. There's a part B, Medicare B, I think, that ACAC puts in the code. I can now order the supplies, and we have home health care coming from ACAC in a nurse practitioner and in an OT and PT. And speech.
Well, you can do ACAC 60 days for $60. You get a doctor's prescription. That's an easy.
We don't pay anything. Medicare pays for this. Medicare wouldn't pay for it. But Medicare is paying for this now.
You don't
Yeah, United Healthcare gives you
I get doctors
no charge. If you have Medicare with United Healthcare.
Well, I have a question. One thing that when I see patients really fail with therapy or exercise in general, is that they're doing well, they're doing their exercise, they're doing classes and things like that, but they get admitted to the hospital or they get some illness and they like out for a week. Then after that, it's very hard for them to restart. So what advice would you give in those situations?
I personally would say, get another PT referral to get jump started again and address new issues.
I would say also care partners, if you find that your spouse or family member isn't, maybe reach out to that PT or OT or speech or trainer and maybe have them call that person and be like, hey, like, you stopped coming, like, put the accountability on that trainer or PT, OT to reach out to them and be like, hey, we really miss you. Like, I know things aren't going well right now, but we would really like you to see you back in the gym or in the clinic.
What did you have to say?
I just have a suggestion that just like with a physician or a gym where you're comfortable, not all physical therapists are the same. And I can't tell you how many times in 44 years I've heard, well, physical therapy didn't help. Well, maybe you didn't have the right click, or maybe it just wasn't the therapist that had the expertise that you needed to have. You don't want to come to me if you have a shoulder injury. I'm not going to be the one that has that expertise, but you need to find someone that you meld with and have an intermittent relationship. Your doctors, if you're anywhere associated with any of the neurologists around here, they'll support you going. And it's all about the comfort at the facility, your willingness to go there and be there. Partners make a huge difference, but you also have to find someone that you know is making a difference for you and is identifying, supporting all the good things you're doing. And you may not be having problems yet. It may be like Dr. Fagari said, well, I'm fine, I don't need physical therapy. You might have subclinical or, small impairments that right now aren't a problem, but can be remediated early and help you keep moving down the road. So if you didn't have success with this particular PT, OT, speech therapist, it's not that they weren't good people or weren't good therapists. It just wasn't maybe the right match. So check around, see if there's someone else, see if you have friends that have had success with someone else.
Or if there's even another therapist at that same clinic, you could always ask the front desk,
Good point.
I'm really not clicking with this person. Is there any other availability on anybody else's caseload? That's usually a nice, easy, quick fix right there, and you're not having to worry about moving where your prescription is at or having to go on a wild goose chase to find a new provider, a new place to go. And honestly, as therapists, we're not going to get offended if we're not the right fit for you. And I can't speak for how everyone else is going to feel, but you need to do what's best for yourself. And we understand that. And we want what's best for you too. So if that means finding a different provider, then that's what you need to do.
Is Encompass Health still an extension of UVA or no, not really? Because they had great services there.
So the Fontaine clinic, the UVA clinic, was previously known as Encompass Health Outpatient. Encompass Health as a company no longer provides outpatient services anywhere in the country.
Oh.
They have closed all of their outpatient centers down, and so UVA has purchased the outpatient center here, so it is still in operation. It's just under that new name. Encompass Health, as it stands, is an inpatient rehab center still, and that is still affiliated with UVA through the joint venture program, but it is not providing outpatient services.
Can you tell me the
PTs
therapists
are
that
most-
were at Encompass Outpatient are the ones?
Yeah,
at
they're all the
UVA
Yeah, it's the same
Neurology.
people.
Yeah.
almost.
There you go.
All the same good people.
Yes.
Yes.
I have a question for speech therapists. I was very naive in what you do because I think speech, but you do much more than that. Can you help me understand? So when I'm with people who Parkinson's specific, how you help them, or in general, what you do?
What I do. I think it's a little confusing that speech therapists also do swallowing disorders, which is very common and often can cause a lot of illness, like the pneumonias that can come with Parkinson's are often related to difficulty swallowing. So ideally, we would want people getting swallow studies intermittently when they come to clinic. I like to try to get a baseline to see how they're doing, and then sort of take proactive measures, every couple years, like recheck back in. And if they start developing swallowing problems, like the same with PT and OT, let's starting therapy early to help get those muscles stronger and more coordinated. There's also some breath exercises we recommend to get their cough strength to be more efficient. So if anything does go down the wrong pipe, you have more strength to cough it out and for it to not end up in your lungs. So as far as swallowing disorders, it's like a monitor, and then if things start to look a little weak on an x-ray, then we would start therapy. For speech, I often think that like a soft voice is usually sort of a first sign for people, or maybe their speech sounding a little bit less clear than normal. And even in those very early stages, that is when therapy can be the most effective in teaching strategies to overcome that. So if we start like an Elise Silverman voice therapy, like the big and loud, but just speech therapy. There's another one called Speak Out that's very similar. Starting those early shows more benefit down the road, and then just sort of checking in, maybe 2-3 years down the road, you're like, oh, I'm starting to go back into that softer voice and less clear speech, then you could do a check back in with your speech therapist and sort of fine tune things again.
I know that we had talked about earlier about how exercise is super important and how you should do it every day and remind yourself. Speech is something else that you need to be doing every day, practicing every day, because that is going to be lost if you do not practice it, right?
Yeah.
And another thing that we talked about, like exercise in a group setting and then PT, we have some people at the park who do our boxing classes on Monday, Wednesday, go to PT Tuesday, Thursday. Just because you go to PT doesn't mean you can't do other exercise programs and vice versa.
On a slightly different tangent, I think one thing it can happen as a catch-22 is if you exercise, at least for me, like sometime the next day, my Parkinson's is actually worse for a day or two. Just because I guess I've used the muscles so much. So you have to kind of say to your mind, this is just a temporary thing. I have to keep up with the exercise, not let that kind of get you stopped.
Yeah, we suggest every other day for the gym. Sometimes people are like gung ho, want to do it every day, and they injure themselves. But like you were saying, you may not feel very good the next day, but like you said, you have to go back.
You're
Jim.
challenging your body, right? And that's how.
Yeah, it's like if I go on a 40-mile bike ride, I'm gonna be shot the next day.
Oh, yeah.
So will I.
I think everybody.
It's not 0.9 miles.
Jim, was it you that said, if you don't leave the gym exhausted, then, or someone said to me where it's like, if I don't leave the gym exhausted, then I know that I didn't push myself hard enough. Something like, was it you? Could have been.
No.
Also, you just got back from vacation, right?
Yeah.
And what did you say to me when you just got back?
I stiffened up. I'm one of those people that can't exercise by myself. So the group is very important to me. And after the first session back from exercise, my muscles were normal, not stiff. And it comes from pounding that bag.
But you also said that without the exercise programs that you're part of, you wanted to have been able to keep up with your family, right?
Right, yeah.
You guys went hiking in Arizona?
Mm-hmm.
Nice.
And I'd like to put in a plug for ping pong.
You keep trying to get it at the gym, we don't have to face yet.
Ping
That's what
pong.
pickleball is like, the perfect in between of ping pong and tennis.
We did a pickleball clinic back in October, right? Yeah.
But the center at Belvedere offers 4 sessions of ping pong. They've just expanded from 2. They have 4 tables and
They have Parkinson's yoga now.
Oh.
I need a cane to get into the ping pong room. And once I'm playing, I can jump and, it's a transformation.
He loves ping pong so much that they took their sunroom that overlooks their pool and put a ping pong table in there. And Heidi doesn't have to participate with them. They have a little machine that shoots the ball down. But that's something that he loves to do.
Similar to what Dr. Nagari was saying, you know, with Parkinson's, with it being progressive or an injury or something, and then they get hospitalized. I work in inpatient OT as well, and what we go into trouble is like patients don't get their meds on time because the nurses are behind, and so that could impact then how they get up. And then if they stay in the bed, they could aspirate on their food, thus requiring this snowball effect. And then when they come out of the hospital, then it's like back to square one. Do you guys have anything implemented at UVA that could help that process in terms of when there's a hospital admission for whatever reason?
I mean, we all advocate, I think, as much as we can. It certainly happens, you know, like patients can't get medications because they're going in for surgery or
Right.
something happens and they're in the emergency room all night. I mean, it really affects speech and swallowing too. And I just try to, like, as soon as we get a consult, I call the nurses and say like, this person needs to be taking their medication as prescribed, and like, I will come in after that dose. And sometimes I think for us, it pushes them a little bit more to get to it if they know, like, okay, the patient's also waiting to eat until speech gets there.
Right.
There is Parkinson's Foundation has what's called an aware and care kit. So at the gym, those who are members have received the new copy of it. It's a booklet and you can get it for free. They'll send it to you, I think, right, Lisa? Yeah. So you had ordered it by yourself, but it's an aware and care kit, hospital safety guideline for both emergency and non-emergency visits to the hospital. What it does, it has checklists to do. Okay, I'm getting ready to the hospital. Do I have my medication list? Do I have all these things? What do I need to tell the doctors? And then in the very back of it, it has forms you can rip out and you can give it to the doctor. You can give it to the nurse and say, hey, I have Parkinson's. I should not be given this medication. I should not be given that medication. Then there's also the medication list. So take the time. I'm looking at you guys over there. Take the time to fill out the form. It's a medication list. It tells the emergency contact. It lists your medications, the dosage, and what your timing is. So you can give that to the emergency room doctor. You can give that to the EMS so that they know what the medication is. And make sure your care partner is an advocate for you. If you're unable to talk, make sure that they tell the doctor they need their medication. In my situation, we always bring our medications with my father to the emergency room, and we tell the doctor he has to have the medication at 4:30. He can't have it any later. And lately, the doctors have been like, you can give them the medication yourself. So just make sure you speak up to that doctor, because with UVA or any hospital, they have to put the prescription in. They have to send it over to the pharmacy. Then the pharmacy will send it back over. And by the time you get it, it could be your next dosage.
Right. Do they allow you, so in the past, I've had people going in, at least at UVA, that take their meds in with them and sign off on self-administering.
That, I'm sure that's what happened.
Did that still happen? Can that happen on the floor these days?
They're not crazy about people taking their medications themselves, to be
But
honest.
just specifically their Parkinson's medications,
Yeah.
maybe?
I think that they're more lenient about that. Yeah.
Because I mean, I've had success over the years.
You know, in like a surgical setting, if the people are going in for a scheduled surgery, there is like letting their surgeon know ahead of time. And then that's something that anesthesiology does not like bat an eye about, as far as like making sure that those medicines stay on the schedule, as long as it's not obviously interacting with other things that they're being given. But people will be coming to and like after surgery and stuff. And like, I know that the carbidopa is being administered, but it does take some advocacy on like on the patient side ahead of things. When it is those planned surgeries. Obviously, when we're going to like the emergency department, things are less planned. So it is good to have that kind of emergency medication list and, you know, come in with a plan. And especially if you have availability, a care partner who is able to advocate for you as well. From the therapy side of things, I know that if we typically see any sort of Parkinson's in the history, we're pretty good with talking to either the the nurse to make sure that the medicine is administered or taking a peek at the med list to see if it's even been ordered yet. And we'll page the team to make sure that, hey, did anybody consider that this medicine needs to be there? Of course, you know, there's only so much that we can do from where we're sitting, but we really do try as best we can. But it's definitely a whole lot easier if you do come prepared with that full list for yourself.
And with your medications, I think would be helpful.
I know that Inova, Parkinson's and Movement Disorder spent a good amount of time, from what I understand, going into the Inova system to all the different hospitals, ER and, you know, OR and the whole bit, educating them on the importance of the timeliness of the medication with regard to the food, because typically it's you get your meds and your food at the same time, and understanding that. But also there's certain ones that don't translate to the generic as well. And so they spent a good amount of time, and I didn't know if that's something that UVA's taken time to do to make sure that that education
be a
across
better
the board
question
may
for
be
Dr.
something to
Which was.
to bring to your team to
Yeah.
do that, because they found it made a huge difference for, you know, people not declining when they were in hospital.
What about those of us who aren't regular on taking our meds regularly?
You gotta be regular on your meds. Set an alarm on your phone. That, we found that that's the easiest method.
Yeah.
You just, you can do it every day. Set it for every day.
Every day.
7 o'clock, 10:30, or whatever your timing is. And it will just repeat it over and over. And yes,
There's an app called MedSafe where you plug in your medication, your dosage, how many times a day, and it gives you a reminder. So I get a little pill shake bottle, and that's when it tells me to take my next dose.
That's great.
Little bottles, there's little pocket packs with alarms in them that have a well in it to keep the meds, and then a timer that you can set at intervals.
Wow.
So you take it and push it again, and it goes, okay, 3 hours later, we're gonna do it again. It's nice to have the pills with you, with your timer.
Sarah made a good point about hospitalization and all that. APDA that Naomi spoke about has wonderful publications. So if you don't have them, look into it. And one of them that I love is the hospitalization one. And the other one is medications, because you can get into trouble taking a medication that doesn't mix well with Parkinson. We did that with my mom. It just killed her.
so, yeah, Jim has this on his person, which I tell all my people, take the time to fill it out. It's a medical, this is the wear and care kit part of it. It's a medical alert card that says I have Parkinson's, I am not intoxicated. Someone did not fill this out in the back. Safe medications and medications to avoid. And then also the medication form. So it looks like his wife took the time to fill this out, because this is not Jim's handwriting. So it's all his medication, the daily things, and then he stapled it to fact sheets for the nurses, as well as common symptoms and typical Parkinson's medications. Another thing, and is a story that I heard from a person who recently passed away. He had a hip injury and had surgery, and the doctors flip-flopped 2 of his medications that had very similar names. So please make sure that if you have like medications that have similar names, check that. Make sure that, because the dosage messed them up.
We put ours, one in the kitchen on the kitchen counter. in
Yeah.
the corner, and then one in the car and one in his wallet.
Yeah.
Wow.
So we have one in the car, one in the gym bag, one in the medication box, and then one with the advanced directive as well.
There are a list of medications that interact with overdose and overdose.
And that's it. I don't have it off the top of my head, but it's medications that you should completely avoid.
Naomi has it out there.
And Naomi has it out there. Okay.
So has anyone had occupational therapy or know what that is or have questions for what OT does?
So yeah, what do you do?
Who are you?
Who are you? So for occupational therapy, we have a very broad net that we cover. So the big answer to that is anything that you need to be able to do or want to be able to do in your day-to-day, we help you be able to do those things. What that looks like more specifically is, can you bathe and dress and get to the bathroom on time? Can you cook yourself meals? Can you go grocery shopping? Can you take care of the house? Can you go play pickleball if that's what you want to do? Can you can you get out into your garden if that's what's meaningful to you? It's really kind of my job to come in and help to problem solve for how we can keep you doing all of these things as long as possible and as independently as possible, even if it has to look a little bit differently than how you might have done it before. So in the terms of Parkinson's, it could look like maybe we're introducing different types of gadgets or equipment that make things a little bit easier, especially if you have tremors that affect your hands, you're dropping things. It's harder to say like tie your shoes or button your coat, things like that. Maybe we have some fixes for you. We can give you some strategies from that side of things. It could look like energy conservation. You know, you're exhausted. We're not sleeping at night. We're having a hard time being able to get the things done throughout the day that I need to get done. How can we look at your daily routine? How can we look to see how much energy you're putting into each aspect of your daily routine to make sure that you're still able to do all the things you want to be able to accomplish in a day, and making sure that you're meaningfully engaging throughout your day-to-day routine. So it is very, very broad. And it's also one of those things where it's like, at what point do I need to go see an outpatient occupational therapist? And I think that's probably the best question, right? And we don't have an exact answer for you, unfortunately, because everybody is going to look a little bit different, just because everybody's Parkinson's journey is a little bit different. And it also might depend on the amount of assistance you have available to you at home, the amount of support you have either within your home or neighbors nearby, et cetera. But research shows that the earlier we can get those strategies or interventions, or even just connected to like the idea of occupational therapy and from an outpatient basis, even if you just go a couple of times in the beginning, and then that way you kind of have an in the next time that things are starting to get harder, that actually helps to keep you as independent for as long as possible. So yeah, that's kind of the quick and dirty about what we do as OT.
How about Lisa, next time we have an educational event, you'll tell us how it went.
I'm not sure my house cleaning skills have anything to do with Parkinson's.
Will be laundry.
I understand. Going back to the physical therapist, when I was first diagnosed with Parkinson's, I was mad. I was really angry. And I just felt like the word exercise kept coming to me. So my church had just built a gym and I joined it. And they gave us 6 weeks with a trainer on them. And she was awesome. When I told her I had Parkinson's, she said, "Would you work with me for 6 weeks? I'll get you." Because I was like this. I couldn't even pick up my infant grandson. So within 2 weeks, she had me relaxed. So I worked with her for a year. And it's amazing. If you don't exercise, it's hard to do it every day. But when you have somebody that holds you accountable, it makes a difference. And after I was finished with the training, I joined one of the classes. And we had camaraderie, we had understanding. And if I wasn't there, where were you? Why didn't you come? So it's actually a lot of fun. I look forward to it after I got used to it, but you just have to make yourself do it.
And it can be tough to start something new, especially if you're going to like a gym or a class by yourself, right? It kind of puts you in this weird spot where it kind of pushes you out of your comfort zone. But it's, again, getting over that hump and then kind of developing that community and that having those accountability partners that can kind of check in on you, but also you look forward to going and seeing and sharing that time with. It is very meaningful.
I think cakes and took them in, so I ruined their exercise. They enjoyed the cakes.
I think also like you might have a symptom that you're embarrassed about, and you might be worried that if you go in a group setting, someone's gonna say something. But the nice thing about finding a Parkinson's exercise group is that everyone has Parkinson's. So if you're having a bad day, they'll understand that you're having a bad day. They're not gonna be like, "What's wrong with that dude?" And they'll cheer you on and make sure that you're reminding yourself of, okay, yeah, I'm freezing right now. What did Sarah or so-and-so trainer say to me, my PT, my OT? If I'm having a hard time speaking, what did my speech therapist tell me to do to get out of this frozen state?
There's a girl in our boxing group who stated it's the one place I go where I feel normal.
Me too.
Have you heard of Strive PD? It's the app, that's a good app too.
And I'm from Richmond and I know it's a lot of people in the room from this area, but there's a Power Over Parkinson's at the Gold's Gym in Richmond that is focused, it's free. It's for people with Parkinson's and it's very well received.
We have Richmond people who, or sorry, Lynchburg people who rock steady down at the YMCA. And you're in, where are you? Lynchburg, you guys are all together?
Yes.
Dang, all right. Culpepper?
PT and rock steady boxing class. And they're hosting our support group meetings. Great center, if anybody lives north of here, Culpepper is moving up in the Parkinson's world, and
Okay.
it's got a great exercise club, pool, and they have ping pong, they have a pickleball, they got it all, but good program. Most of the doctors in Culpeper are now under UVA too.
Lou?
So I would like to mention that the Charlottesville Ballet Company has a free Parkinson movement class on Fridays at the X Complex at 3:15, and it's free of charge for people, so.
There's also one in Harrisonburg that JMU runs.
Right.
A dance class.
I wanted to say one thing, it just remind me of it. I found when I was working full-time, there's nothing for people working full-time in the evenings.
Yeah.
Everything's during the day. It's really frustrating.
Yeah. And that's, we have 65 people at the park, only 2 or 3 are still working full-time. So our latest class is at 3:30. If there were more of our coaches, only myself and Carrie, we would probably do an evening class. We also have like an early morning class, an 8:30 class, but we understand that those who are still working, it's hard to make time. Those people who are still working, on the days they come to work, they leave work at 3 o'clock and they make that exercise a priority.
You can always do some of the online Parkinson's
Sure, yeah.
oriented exercise things if you can be motivated to do that. And the other thing is, it doesn't have to be Parkinson's related. I mean, I've certainly had people early on, they're like, well, I don't really want to associate with Parkinson's, right? I don't want to like go see other people with Parkinson's who may be worse off. You know, we'll do some other sort of exercise. No, it doesn't if you can't make it to, you know, a Parkinson's related thing, you can always do something.
Yeah, I, was diagnosed a little over a year ago. I'm just now, I was 58 then, so, still trying to work full time. And the general neurologist who diagnosed me, and I kind of suspected that's what it was, but she was kind of like, if it were me, I'd go start exercising like right away as much as you can and all like that. And I'm thinking, that sounds great, but I wouldn't do that if I didn't have Parkinson's probably. And so, I'm still struggling to make time. And I mean, I was a golfer. That's not, some people don't consider that exercise, but.
Oh, I bet.
I get it.
You can walk the course.
I could go walk 18 holes. I could go walk 18 holes, and I can do it.
You should play speed golf. Have you ever heard of speed golf?
No, that's all right. So, yeah, it's just hard to find the time and make the time.
You got to make it a priority.
You do. It's your health.
Yeah.
Has everything to do with it.
Well, I guess my question is, how do you figure out, and I know this is a unique question for everybody, but, in terms of knowing the progression of this disease, the big question is how long do you keep working full time versus trying to focus on your health full time? It's really a delicate balance. I don't know if anybody has that answer, but I'd love to hear that addressed.
Well, and I think that's kind of a personal question too,
It
right?
is.
Because for some people, maybe it is much more meaningful to try and keep working for as long as I possibly can, because that's how you would have been with or without the Parkinson's. Parkinson's was just kind of added on top, so to speak. But I don't think that there's an exact answer for you, unfortunately, as far as this is when you should cut it off because what I have seen and what I have witnessed is that a lot of times when people retire, they actually stop moving. That's the time when it's like, I'm gonna have so much time for, and then we stop doing anything. And you find that you're watching more TV, you're sitting on the couch, you're staying more of a homebody, which is totally fine. There's nothing wrong with. But then all that time that you were going to prioritize for your health, you're still not prioritizing for your health. So I think it's really, really hard to give a definitive, it has to be done this way, or it needs to be done at this time. I think it's really kind of a little bit balls in your court about what is important to you and how are you going to make that important to you piece kind of the top thing to do. And I will say having somebody else to do the exercise with is usually a good place to start, because that can be very motivating in and of itself. Time is hard, right? Trying to find the time for it. But also, you know, even if it's just you start off once a week and then you can add in a second time a week, and then you work your way up to that third time a week to where it does become part of that routine. It's a whole lot easier to do it that way than to try and like do it all at once. It's a much more of a struggle if you're trying to like drink from the fire hose, so to speak.
Also, does your job bring you joy? Right?
Yeah,
Because joy
yes.
brings dopamine, you know,
Yeah.
it's all part of it. So if you get joy from your job, by all means, right? Anything that brings you joy.
Excellent point. How do we get to the top of the list of this collaborative interdisciplinary site visit?
You're right there.
Can we be at the top of the list? Thank
So it's like Dr. Bine was saying, we still kind of like in the pilot process of this project. We are seeing patients one day a week, about between 2 to 4 patients on Wednesday mornings. And I think that it's gonna be done through your neurologist. So your neurologist has to kind of sponsor you to get to this clinic. But the problem is that you imagine we have 4 neurologists seeing, each one of us is seeing about 20, 30 patients a week. And we're only seeing 4 patients once a week in this special clinic. So the idea is not that patients are going to be rotating there very frequently, but we want that at least our patients start getting there maybe at least every couple of years, or maybe once a year, once we have this running more efficient. Yeah, no, there's not a good answer of how to push up into that. We're prioritizing now patients who are having a lot of multiple problems at the same time that really are gonna get the best points out of spending the whole day with the group.
They present your case to the neurologist treating you.
Which could be him.
You presented your case in front of witnesses.
Telling your name.
30 witnesses saying that.
I think all of us top of the list.
I think the other thing we're hoping is, once you do come one time, even though we might not see you for years, then you kind of have a team of people that you can send messages to through my chart to, or ask questions to, you know, over time.
I have kind of a simple question for physical therapy. How do you know the difference between a good cardiac workout and just being winded because you're out of shape?
Well, if you're getting winded because you're out of shape, then it is a bit of a workout, right? So you're starting at a different place, but as long as you're increasing your own heart rate and breathing rate, you are getting that benefit. And over time, as you get more in shape, you'll still be getting, you know, winded and tired, but your heart rate and your breathing rate will be better accommodated. So either way, it's aerobic. If you're starting at a low place, it's still aerobic. And then as you get better in shape, you can do more and more.
And I don't know what you think as the PT, but personally, when I exercise, like I really like to monitor my heart rate as like sort of a judge of how hard I'm working out, you know, on days where like I just worked a 10-hour day and then I'm going to try to work out. Like I may perceive that like I'm working out really hard. And then I look down and I'm like, oh, my heart rate's at 90. Like probably I'm not pushing myself nearly hard enough, you know? So it can be helpful to have just like an external something to look at.
Yeah, these days you can get pretty cheap fitness watches.
And if you're low endurance, you don't have to start with 30 minutes of a hard workout. You want to start with intervals that are shorter and spread out throughout the day. So over the course of a day, you can get the time in, or even build up over the course of weeks, so you can increase your time. But don't feel like you have to start at a high intensity for 30 to 35, 40 minutes from the get-go. To give yourself time to build up, especially if you've been like hospitalized and ill, to get yourself back going again. But also if you just haven't been able to exercise and you're trying to get started again.
And I think something that's super important for any exercise group, and what should be for Culpeper and Lynchburg, and I know that our rock steady, in any rock steady, they should split between the different levels. So if you are needing assistance, you might have memory issues, you might have extreme balance issues, you should be in a class that has that, or at least in a group that other people have that. And then if you can complete the exercise by yourself, and you might need slight modifications, you're in a group like that, so that those who can do higher intensity exercises aren't being slowed down from people who may not be able to keep up, and vice versa. That group who needs a walker or a cane aren't gonna put their safety at risk for trying to keep up with the faster group.
Or if you're in the earlier stages of disease and maybe you're not using any of those assistive devices to get around, and you're not going to like the park classes or the rock steady boxing, but you're going to just a normal gym class. Typically those class group exercises, the instructor is going to show you kind of the high level, a medium level, and a low level, and you can kind of pick what is going to work for you. There's always different variants to that exercise, and you kind of have to judge, you know, what is going to work for you. And even if, you know, we're trying to get over that hump and just move, you know, even if you can just, if it's not necessarily giving you the highest heart rate or anything, but you just stay moving for that entire class, that's going to be way better than, you know, not doing it at all, because, you know, we're just discouraged by the prospect of having to get there.
And maybe for you or someone in that situation, like an online class might be a good option, because you can stop and rest, you know, as needed during whatever the instructor is doing, take a little breather, get back to it, or not, you know, not work quite as hard maybe as what they're doing, and kind of build yourself up that way. Instead of feeling like you have to keep up with the whole class.
So Jim reads the news to me every morning as I'm making breakfast. And I think his voice has, you know, stayed pretty much the same, has been pretty good. So my question is, do speech pathologists recommend reading aloud? And is that something that has proven benefits?
I don't know if it has proven benefits. It certainly can be helpful, especially if you're paying attention when you're reading, to like reading loud enough so she can hear you, and trying to pronounce the words more clearly, and paying attention to your breath support. I think doing it with intention can be helpful. I don't know if there's research supporting that, but I think it is helpful.
I have a question. I am auditioning for a local chorus, and I want to know if it's detrimental for me to be singing like that for a couple of hours every week. So if I won't strain my vocal cords by trying to do this.
I think it would be great. I mean, for the breath support involved in singing is wonderful. There are